Evening, everyone.
Namaskar. Namaskar and good evening, everyone. I welcome you all on the second day of education series Lung Cancer Congress and Rare Thoracic Malignancies. And with immense pleasure, I would like to invite Dr. Nandini Menon, who is Assistant Professor Medical Oncology, Tata Memorial Hospital, Mumbai, to set the ball rolling and for further proceedings. Over to you, ma'am.
Thank you, ma'am. Good evening, everyone. And I would like to welcome everyone to day 2 of this virtual education series on lung cancer and rare thoracic tumors. On the behalf of the organizing team, myself and Dr. Ashay Karpe, we extend a warm welcome to all our faculty and our audience. And we hope that today's program is a success. So without wasting much time, we move on to our first session for today, which is on lung cancer. And this session is sponsored by Pfizer. I would like to invite our first speaker for this session. And I would like to invite Dr. Shivam Singla, who is a consultant medical oncologist at SL Raheja Fortis Hospital, Mumbai, for his talk on lorlatinib in the management of ALK-rearranged non-small cell cancer. Over to you, Dr. Shiva.
Thank you, Dr. Nandini, for the introduction, and I would like to thank the organizers today and Pfizer team for giving this opportunity to me. My job here is to tell you about the crown data in lorlatinib and briefly review the lorlatinib as a drug, which we have been successfully using in the recent times. So, Garima, if you can share my screens. Can you play this? Yeah. So, can you go to the next slide? So I'm going to present today data of Crown trial data, which suggested that lorlatinib as a first-line option in metastatic ALK-positive NSCLC, and which has sort of changed the paradigm of this disease completely. If you look at the disease background in lung cancer, it is probably the second most cancer causing death, commonly diagnosed and causing death in 2020. And I feel the incidence of lung cancer is tremendously going up. NSCLC accounts for 80 to 85% of cancers. I see small cell cancer rarely now in my practice, and I think my colleagues will echo the same. It is probably because, I don't know, because of more filters coming up, the incidence of small cell cancer has gone down. Even in smokers, we are not seeing much of small cell cancers. The 5-year survival rate is still dismal, in patients with non-small cell lung cancer, and it's only 7% in patients with distant metastasis. So if you look at this pie chart, which has been taken from Piker et al. In lung cancer, you can see that lung cancer today has evolved from NSCLC, HCLC to adenosquamous large cell and other lung cancer subtypes. Can you go to the next slide? Garima, next slide. I think, Garima, can you hear me? Next slide. Or let me share my screen. Which says that how the lung cancer, is varied between male versus female, how the demographic change has been. That now we are seeing more and more females with diagnosed with lung cancer, and by 2040, WHO predicts that the difference in the diagnosis amongst male and females would diminish in terms of diagnosis of lung cancer. And this is a Globocon 2018 data, which is very, very fairly reliable. And this is what we are also seeing more and more in our clinical practice. Can you go to the next slide? Garima, next slide. see that the estimated number of deaths in lung cancer are pretty high, and this is an age-dependent phenomena. This is a dependent phenomena which is increasing over a period of time. By 2040, the World Health Organization predicts that in India you would have close to 1,11,804 patients being diagnosed with lung cancer, and we can see that in our practice also today. Now, when we talk about the mutations, we know that lung cancer is a mutation-driven cancer or immune, responsive cancer. ALK positive mutation is generally seen in adenocarcinomas in lung cancer. This was a paper published by Amanjeet Pal and Navneet Singh et al., which showed that in India, in northern India specifically, the incidence of ALK positive mutation was as high as up to 8%. Different papers have shown this incidence to be between 1.6 to 11.7%, but in our practice, we close to see as close to 6 to 7% of the patients will end up having lung cancer. ALK rearrangements in lung cancer can be of multiple types at multiple domains, but they tend to have a similar morphology of patients. These are typically adenocarcinoma patients. They are typically never or very light smokers. They tend to occur at a younger age. There are a lot of diagnostic techniques available today. We are using NGS. Most of us are using NGS as a common platform. And they are mutually exclusive. Rarely we find patients with biclonality and both mutations, but majority of these patients have a single mutation. The discovery of ALK fusion was done in 2007. And since then, there has been a lot of newer therapies which have been directed successfully against the management of this cancer. A small number of patients have an inversion at chromosome 2, which leads to fusion of, ALK gene with EML4 gene, resulting in ALK EML fusion protein. This is the pathology that leads to, driving force as far as this lung cancer is concerned. When we look at the timelines in terms of ALK positive tumors, the ALK fusion was detected in 2007. The first drug was approved as crizotinib in 2012. But since then, there has been a plethora of drugs from alectinib, ceritinib, brigatinib to alectinib being approved as the first line to lorlatinib, being approved as a first line in 2021. At present, what are the unmet needs? ALK positive young patients are generally younger. They have a larger survival advantage from starting a drug at an earlier stage. They are non or light smokers. CNS metastasis is quite high in ALK positive tumors. It can occur in up to 20 to 40% and associated with poor prognosis. There are a lot of resistance which these tumors generally develop on the first line of therapy, and they become resistant to the subsequent usage of the same TKI. And untreated patients, there are resultant clones. When we treat that with second or third generation TKIs, the incidence of clonal population having resistant clones goes down. Lorlatinib is a third generation ALK TKI. It's selective, ATP competitive, highly potent drug. It has an excellent brain penetration, 75% to address brain metastasis. It has a potential to improve clinical outcomes with overall survival and intracranial activity. In addition, upfront could completely suppress or delay the onset of target mutations. When you compare lorlatinib with a crizotinib, the molecular structure of crizotinib is open as compared to lorlatinib, giving it a smaller molecular size and a higher brain penetration. And it binds more highly effectively to the ALK resistant mutations, typically the G1202R and G129A. Let's look at the CROWN trial. This was one of the landmark trials which was reported in NEJM in 2020, where ALK positive patients were compared between two subgroups of treatment of lorlatinib and crizotinib. This trial randomized patients with stage 3B, stage 4 ALK positive NSCLC in the first line setting with or without CNS metastasis and more than one extracranial lesion into lorlatinib versus crizotinib group. The groups were further stratified in basis of ethnicity and the presence of brain metastasis with with a target to measure the both progression-free survival, overall response rates, both by independent reviewer. So the study enrolled close to 300 patients and they were randomized between May to February 2019. All patients underwent a restaging CT chest and brain imaging every 8 weeks. 103 patients were in the lorlatinib group 147 were in the crizotinib group, 149 in the lorlatinib group, 103 patients in the lorlatinib group, and 31 patients in crizotinib group remained on the study treatment. Median duration of follow-up for PFS was 18.3 months and 14.8 months respectively. The baseline characteristics, both the groups were fairly well matched, and majority of them were never smokers, but some previous smokers were also there. Very infrequent number of patients were current smokers. If you look at the brain metastasis, very high number of patients had brain metastasis, 26 patients in lorlatinib group and 27 patients in crizotinib group. Some of these patients had received prior radiotherapy to the brain. So it was very interesting to see the primary endpoint in terms of progression-free survival. The progression-free survival almost doubled at 12 months, and the curves were so far apart that it was very obvious that which was the best drug. The hazard ratio of 0.28 was very impressive. The median PFS was not reached in the lorlatinib group. It was 9.3 months in the crizotinib group, as seen in the previous studies with crizotinib previously. When you look at the progression-free survival by independent investigator, you can see that the drug did fairly well. Up to 80% of the patients were doing well at 12 months, and which was very comforting, versus 35% of the patients in the crizotinib group. When we looked at the subgroup analysis, non-Asian patients did fairly well. Then the Asian patients, the patients with brain metastasis did fairly well with lorlatinib as compared to crizotinib. Never smokers did much better with lorlatinib as compared to crizotinib. The overall response rates were fairly decent. You can see patients with partial response 73%, patients with some form of a response close to 80 to 90%, and median time to response was only 1.8 months, which was seen similar in both the subgroups. But what was interesting is that the intracranial response was much higher in the lorlatinib subgroup as compared to the crizotinib, and this was this was one of the most important milestones that we want to achieve in our patients, especially with brain metastasis. So you can see the intracranial time to progression by independent reviewer. The lorlatinib did much better as compared to crizotinib, and this is primarily because of the indigenous nature of the drug to cross the blood-brain barrier. Majority of the patients with lorlatinib did remain brain metastasis free. In terms of overall survival, it was not reached in both the subgroups with the hazard ratio of 0.72. This also favored lorlatinib-based modality. The study period was less, and the final results of this overall survival will be interesting to see whether this leads to a definite improvement in overall survival in future. In terms of safety profile, the safety profile was almost similar in for both lorlatinib and crizotinib, as fatal and adverse serious events, but of the similar proportion. In terms of permanent discontinuation of treatment, again similar proportion of the patients had to continue or discontinue the drug. The most common side effects of observed with lorlatinib were hypercholesterolemia and hypertriglyceridemia and edema. And few of my patients who are on this drug, this is one of the most common problems that they are facing today. Rest, it's a well-tolerated drug. It leads to some mood disturbances, some vision disturbances, but in other terms, in terms of causing liver dysfunction, in terms of constipation, in terms of nausea, it's a much better drug as compared to crizotinib. If you look at the quality of life survey, lorlatinib was superior to crizotinib in terms of quality of life. Majority of the patients felt on lorlatinib felt better as compared to crizotinib in terms of quality of life. So in conclusion, and this is my one of the last few slides, lorlatinib resulted in significant longer PFS, higher intracranial responses as compared to crizotinib. The intracranial response rate was 82% in lorlatinib, with 71% had a complete response rate. The safety profile of lorlatinib was fairly good. Grade 3, grade 4 were more frequent with lorlatinib as compared with crizotinib, but however, the majority were laboratory abnormalities and they did not result in discontinuation of the drug. These results support the use of lorlatinib as the first line. NCCN also recommends as a category 1 recommendation to start lorlatinib as the first line in comparison to ceritinib or crizotinib. How do we manage hyperlipidemia? Pitavastatin, pravastatin, or rosuvastatin should initially be considered based on the low involvement of CYP450 enzyme. I screen all my patients for triglyceridemia at the start of diagnosis and subsequently. Make patients regularly aware about monitoring the cholesterol and triglycerides level. We do it at baseline, 1 month and 2 months, and periodically thereafter. And hyperlipidemia generally resolves with lipid-lowering drugs. Also encourage these patients to use exercise and lower lipid intake. The CNS effects, generally it leads to mood alteration and cognitive and speech disturbances. They were more common in patients with brain metastasis, up to 71%, and 24 patients required more than 1 dose modification because of the drug CNS side effects. If you look at the drug side effects in terms of lorlatinib-related CNS, when we have mild or a grade 1, we continue the same dose or with elder dose until the recovery to the baseline, re-challenge by reduced dose by 25 milligram. Grade 2 or moderate to severe, we withhold the drug until it becomes grade 1 and then reduce it by 25 mg. When they have a life-threatening drug, any intervention is indicated, permanently discontinue lorlatinib. This is for the company's recommendation. So with this, I would like to thank the organizers again and sort of end my talk. The podium is back to Garima and Dr. Nandini to take it forward. Thank you very much.
Thank you, sir. Thank you for that elaborate discussion on lorlatinib. Sir, my question would be, since there is good data for use of alectinib as well as lorlatinib in first line, what would be your choice for first line of drug?
Again, both drugs are fairly comparable in terms of benefit from the first line of therapy. I use lorlatinib in my practice. Side effects are fairly manageable and the drug support programs are fairly robust. But I do give options of both the drugs, and majority of these patients would choose based upon the pricing differences between the two drugs.
Okay, sir. Thank you for your comment and excellent talk. Now, moving ahead to our next session, next talk, I would request for the next talk, Dr. Nandini Menon, who is Assistant Professor, Medical Oncology at Tata Memorial Hospital, Mumbai. She would be discussing about the topic, meeting the unmet need in NSCLC patients with MET exon 14 alteration. Over to Dr. Nandini.
Thank you, Amit. I'll just share my screen. Are the slides visible? Okay,
Yes,
so moving on. So today's topic allotted to me is meeting the unmet need in non-small cell lung cancer patients with MET exon 14 alterations. And in the next 15 or 20 minutes or so, we'll just go through the role of MET exon inhibition in non-small cell lung cancer and the outcomes in these patients. So this is the Globocan data on the incidence of lung cancer in the world today, and we know that NSCLC is the more common type of cancer. Dr. Shivam also discussed in his talk prior to this, that most of the cases now we are seeing is NSCLC with adenocarcinoma as the predominant histology, and we also know that tumors are found amongst the non-small cell lung cancers, and adenocarcinoma is again one of the where you find most of the mutations. So we come to the MET exon 14 skip alterations or the MET gene mutations that are seen. And just to understand a background about MET and how its role in cancer. So basically MET is a tyrosine kinase, which you can see is on the cell surface on the receptor, and it's a receptor for the hepatocyte growth factor. So MET is a transmembrane, it's a protein. Basically, it has a transmembrane domain, an intracellular domain, and an extracellular domain, just like all the tyrosine kinase receptors. And once there is binding of its ligand, which is HGF, there is downstream pathway activation. There's autophosphorylation of this intracellular part of the MET protein, and then there is activation of three major pathways, that is the RAS, ERK, MAPK pathway, the PI3 K-AKT pathway, and the JAK-STAT pathway, like you can see on the screen here. And this leads to multiple downstream actions which lead to cell proliferation, increase in survival of the cells, and increase in metastasis of the cancer cells. So what happens in MET mutated cancers, and what are the MET mutations that we can see? So any alteration in the MET gene, including the MET exon 14, what happens is the MET signaling pathway gets disrupted. So there are different kinds of mutation that we see. The common, one being the MET exon 14, which I will discuss later. Some include MET overexpression or amplification of the MET gene. All this in the end lead to increased MET activation of the downstream pathways and then lead to oncogenesis. So it is an oncogenic driver. So what we know is that the MET gene codes for the MET protein, and this MET protein has a ligand which is HGF. Now, when there are mutations in the exon 14 of the MET gene, that results in an abnormal MET protein that is created. And as a result of this, the MET protein doesn't get degraded. So we know that there is a juxtamembrane domain which has a part which binds to a ubiquitin ligase enzyme, which helps in degradation of this MET protein. And when this mutation occurs, there's a truncated or a shortened protein that is created, and the part that binds to the ubiquitin seen. So as a result, this MET receptors do not, of them accumulate on the cells, and this is the way the oncogenesis takes place in MET mutated tumors. So in lung cancer, MET mutations can be seen in 3 to 4% of patients. So it is not the common mutation that we see. However, it is important to identify this because MET targeted therapy will significantly impact outcomes in these patients. And as we know that MET mutated lung cancer, from a lot of retrospective and other study data, they seem to do poorly on chemotherapy and immunotherapy, and the outcomes are significantly improved when we target the MET. So again, this is what I said, the clinical activity of immunotherapy remains suboptimal in lung cancers which have these MET14 alterations, and that is the importance of identifying MET in non-small cell lung cancer and treating it. So most guidelines, including the NCCN, recommend this basic panel of testing for oncogenic drivers in non-small cell lung cancer, but the practice varies in different parts of the world depending on the access to the testing facilities or therapy. And EGFR, ALK, ROS, BRAF, KRAS, RET, NTRK, and MET exon 14 skipping mutation all have drugs approved for its target. So like we all know, in our clinical practice, we often see that there is an unmet need to detect rare mutations. It's often that it's not detected. And this is one study which analyzed the number of patients who had complete biomarker testing in patients for these 8 identified biomarkers for non-small cell cancer. And what here, this study was done in the West, and even here only 20% of patients had complete tissue genotyping, and we know in our country in resource poor settings this is far less. So international guidelines are slowly now beginning to recommend upfront testing for MET alterations because of the availability of MET targeting drugs. And like I discussed before, this Kaplan-Meier, as you can see, the MET exon negative and the MET exon 14 mutated patients, there is a difference in survival where the mutated patients do worse than the patients without these mutations. So again, the benefit of targeting MET, those who received a MET inhibitor had a higher median OS as those who never received a MET inhibitor. Now, this is a retrospective data, but this has been also tested prospectively in randomized trials. So now coming to MET testing, or how do we know any patient with non-small cell lung cancer has a MET alteration? So as we know, tissue testing, that is testing on tissue biopsies, is the gold standard, but MET testing can be done both on tissue or liquid biopsies. In the various trials that I will discuss subsequently, including the VISION trial for tepotinib, they allow testing both on tissue as well as liquid biopsy. And there was testing on both the circulating DNA, RNA from the tissue, or again DNA or RNA from tissue biopsies. And in the VISION trial, these three platforms, that is the Guardant 360 platform for the liquid biopsy and Oncomine Focus assay, was used for tissue biopsy, which allowed RNA testing on the FFP tissue. And the LC Scrum study assay, which was predominantly used in Japan, was so again, how do we decide and the differences between cfDNA and CTC? cfDNA refers to the DNA that is in the circulation, and it is elevated in tumors. And of course, the cfDNA concentrations and the levels vary on the type of the tumor, the disease stage, and the treatment the patient is on. And here we can analyze both the DNA and the microRNA. CTCs are very widely, and again, they're not suitable for long-term storage, but you can still analyze, look for mutations in this circulating tumor cells. So again, just to summarize what I discussed so far, identifying rare driver mutations in non-small cell cancer is important because patients will benefit from targeted therapy, and different methodologies are available and they're likely to evolve and improve. And now NGS is being used more and more in the first line. We know MET exon 14 skipping mutations, which are seen, do poorly. Both tumor tissue and liquid biopsy are used for detecting the MET exon 14 skip mutations and other MET amplification in non-small cell lung cancer. Again, tumor tissue is the gold standard, but liquid biopsy may be used in places where we can't get a tumor tissue. Now coming to tepotinib and its role in MET exon 14 mutated non-small cell lung cancer. So tepotinib is a drug. Basically, it is a small molecule TKI, like many of the small molecule TKIs which are already in use. And it is designed to target both the MET exon 14 mutated cancers and those with MET amplification. So today I'll be discussing the VISION study, which was a study which evaluated the efficacy of tepotinib in patients with non-small cell cancer harboring MET alterations. And this was a randomized phase 2 trial. And if you look at the inclusion criteria here, stage 3B or 4 non-small cell lung cancer with EGFR or ALK mutations negative, that is, patients with EGFR and ALK mutations were not included. All histologies were included, and they had to have a MET exon 14 skip alteration, either on a liquid or a tissue biopsy. Patients were relatively fit. They were PS0 or 1, and any line of therapy, that is newly diagnosed or patients with prior 2 lines of therapies, and including prior immunotherapy, were allowed in this trial. And they received tepotinib, which is an oral tablet, which was given 500 milligrams once a day till disease progression or intolerable toxicity, or patients withdrew consent. Now, they had an initial cohort A, which has been published in NEJM last year. And then they had an expansion cohort, that is cohort C, for MET exon 14 skip mutation, NSCLC. And there is also a small cohort which they have included about for MET amplified patients. We will discuss the results of cohort A and C, that is specific to MET exon 14 skip mutations. So this is the number of patients that were included, 275 total patients with the MET exon 14 skip mutations. And the number of patients who were treatment naive, that is those who were being treated in the first line setting, were 137, and 138 patients had received prior treatment. This was a phase 2 study, and the primary endpoint was objective response rate, and RECIST version 1.1 was used, and this was done by independent review committee. And there were secondary endpoints such as survival, PFS, OS, and safety analysis. So again, this was a study which was designed with the clinical practice in mind. That is, keeping in mind a lot of times in our clinical practice, we are not able to get this gold standard tissue because of the limitations with biopsy being invasive, patients not being willing, or the complications or difficulties in obtaining a rebiopsy. And they allowed patients with tissue biopsy, liquid biopsy, and a combined population, which included patients with tissue and liquid biopsy, or tissue or liquid biopsy. So let's come to the baseline characteristics, which includes the patients included in the study. And if you look at MET exon 14 skip mutation non-small cell lung cancer, overall you will see in most studies that the patients are older than the standard general population, general non-small cell cancer population. And if you look at this, most of the patients were over 70 years. So the median age only was 72 years in overall, and it was 74 years in the newly diagnosed and 71 yearly in the group of previously treated patients. So it is a relatively elderly patient cohort. Again, 80%, approximately 80% of patients were more than 65 years old. There is an equal male-female distribution, so there is no predominance, gender predominance. And of course, this study was conducted in the West and in extreme East Asia, that is Japan, Korea, and China. So 2/3 of the patients were from the Western population. Patients were fit, so the 0 to 1 PS, and 80% of the patients were adenocarcinomas. They allowed well-controlled brain mets. So you can see there are patients with brain mets at baseline. Overall, it is around 18.5% in the overall population and 17.5% in those who are newly diagnosed and around 19% in those who were previously treated. So brain mets were allowed if they were controlled. You can see that targeting the MET exon 14 skip mutation with tepotinib showed beautiful tumor responses. This is the waterfall plot, which is showing responses in treatment naive patients. So you can see the orange here shows partial responses, and you can see almost over 90% had tumor shrinkage. So these are all the patients with the partial response. These were the ones with the stable disease. And this is a very good response for a patient with lung cancer. And also, it's not just the response that was seen that was good, but it was also the duration of response, which was 32 months in the newly diagnosed or the treatment naive population. And a PFS median was 15.3 months in this population of treatment naive patients. So not only is the response, there are good deep responses, it is also a durable response. So they were robust and lasting responses to treatment in the first line setting. So just to summarize, overall response rates, what was noted was 54.7%. So complete response or partial response was seen in half the patients. 32 months, that is nearly 3 years, the responses were durable. 15.3 months was the median PFS and 29.7 months was the median OS. Now we know, looking at this data, that in these patients, if this MET was not detected and they were treated with chemotherapy alone, our average overall survival in lung cancer with chemotherapy ranges to around 8 to 10 months. And you can see that this is far better than what we can achieve with chemotherapy. Again, now looking at the group of people who had received tepotinib in the second line or third line setting, again, you can see there is a good response, partial responses seen in these group of patients as well. So we see that these patients do respond. The duration of response is also good. It is around 10.1 months with a PFS of 11.1 months, but it is lower than what is achieved in the treatment naive setting. Another thing to note is that tepotinib had consistent sensitivity to tepotinib therapy. That is, tumors were sensitive irrespective of the method of detection. That is, whether you detect MET exon 14 skip mutations in the tumor in the liquid biopsy or in the solid tumor tissue, there is a response to tepotinib. In the treatment naive, you can see it is both have 54%, and here also it is 47 and 43%. There is not much significant difference. Again, the median PFS is comparable in the treatment naive group. Here it's 15 and 11, and it is on tissue biopsy, and liquid biopsy it's 8.5. So there is efficacy in both the groups. So which is to say that in case we can't get tissue for NGS for MET exon testing, we may also consider liquid biopsy if the facility is available. Again, this is another slide which shows the efficacy of tepotinib in both the first line and the second line and beyond setting. So the Kaplan-Meier, as you can see on the right, here the purple line is the treatment naive group, and this is the previously treated group. And you can see that there is efficacy in both the settings if you look at the treatment with tepotinib. So if you look at treatment naive patients, the objective response rate was 54%, the median PFS was 10.4, and the OS was 17.6. And in the previously treated patients, again, the PFS was 11 and the OS was 19.9. So again, Asian patients, which were a smaller cohort, that is around 1/3 of the patients in the study, also responded and had benefit with the drug, which was similar to what was seen in the overall population. And with Asians, I mean to say Asians, that is Japanese, Chinese, and Koreans. Indians were not a part of the study, so there might be slight racial differences in our responses as well. So tepotinib showed clinical activity in patients similarly in Asians as well as non-Asians. So that was also similar. Now, coming to brain mets, we know that oncogenic driver mutation positive patients have a higher incidence of brain metastasis. And now more and more trials are allowing the use of inclusion of patients with brain mets in trials as compared to the older studies. And if you look at the systemic response of tepotinib in patients with brain mets, it was durable and it was robust. And you can look at this these images on the right, which show the brain mets and the response to therapy. Like at baseline, a target lesion of 11.1 millimeters. At 6 weeks, it was 5.8, and it is resolved. It was a CR at week 36. So we know that there is intracranial activity, and brain mets do respond to tepotinib. Coming to the toxicity, we all know that although these are oral medications which patients can take at home, receptor tyrosine kinase inhibitors in various tumors have their own toxicities, and we need to learn how to manage them. So the most common toxicity seen with MET inhibitors, including tepotinib, is peripheral edema. So if you look at this incidence overall, it was 65% in patients. So 2/3 of patients will present with peripheral edema, and it is seen across all age groups. And it seems to be that the older the patient, the percentage of patients developing edema is slightly higher. The other common toxicities that we see is nausea, diarrhea, hypoalbuminemia, and increase in creatinine, constipation, and fatigue. So how do these toxicities impact on the compliance with treatment? So this table on the left shows the dose reductions, temporary interruptions, and permanent discontinuations. And you can look at the overall incidence in the patients below 65. It's a little, it's lower as you go to the older age group. A slight increase in the incidence of dose reductions as well as interruptions and discontinuations. So I think older patients, like with all other therapies, need to be closely monitored and might require more dose reductions as compared to younger patients. The advantages of tepotinib over other MET inhibitors include a simpler dosing regimen, that is just a once daily regimen, which improves compliance. Again, also fewer discontinuations. So around 14% of AEs, that is adverse events, led to discontinuations. And a lot of the adverse events, including peripheral edema, nausea, fatigue, and diarrhea, are manageable, and they can be managed easily with simple dose modifications. And to remember, the most common AE, that was peripheral edema. So peripheral edema, though it is very common, it is the severity or the grade 3 or higher peripheral edema leading to discontinuation or complications was very low. Only 10.7 patients had grade 3 or higher. And because of edema, only 4 patients had to discontinue therapy. So important in a palliative setting and in a disease which is metastatic, as like we all know, is not just improvement of outcomes. We also want to look at the toxicity profile and the quality of life. And they use the URTC QLQ 330 and the LC13 questionnaires to assess the quality of life in these patients. So this is the quality of life that you can see, and this shows the time to deterioration of quality of life. So what they look at is the baseline quality of life and how long it takes for the patient's quality of life to deteriorate. And this is in 2 different age groups, that is younger patients less than 75 years and older than more than 75 years. That is 2 groups that they looked at. And you can see more or less that the quality of life after about a year, it stabilizes and there is hardly any deterioration. Patients only had mild cough, dyspnea, and pain, and there doesn't seem to be much of a difference in the age group. That is almost everywhere the curves are overlapping. So probably younger and older patients, the drug doesn't deteriorate the quality of life more in older patients. It doesn't appear to be so. So we can see that there's a stabilization of the quality of life of patients around 9 to 10 months of therapy, and that is maintained till around 3 years. So it is a good option for in a palliative setting because it doesn't cause the deterioration of the quality of life in these elderly patients. So to summarize, tepotinib is a simple oral once daily regimen, which can be used in patients with MET exon 14 skip mutation positive non-small cell lung cancer. In the first line setting, it has an objective response rate of more than 50% with 90% tumor shrinkage and a very long duration of response of nearly 3 years. And it's once daily oral dosing. It is also a flexible inclusion criteria, that is, they allowed liquid or tissue biopsy. Toxicities are seen, but they are manageable with dose reduction, and the incidence of very severe grade 3 or higher toxicities leading to dose discontinuation is less. We also saw that the quality of life deterioration did not happen. It was stabilized after a few months of therapy, and both older patients, that is more than 75 years, also did not have a significant negative impact on the quality of life. So with this, I would like to conclude. Thank you, and I'll hand it back over to Amit.
Thank you, ma'am. Thank you for such an elaborate discussion on this topic. Now we move on to our next session, which is discussion on one of the rare thoracic malignancies, thymoma and thymic carcinoma. In this session, first talk will be discussing about the pathology of these tumors. For that, I would invite Dr. Rajiv Kaushal sir, who is Professor, Department of Pathology in Tata Memorial Hospital, Mumbai. He will be discussing about the pathology, especially the various ISCs in thymoma and thymic carcinoma. Over to you, Dr. Rajesh, sir.
Thanks, organizers, for giving me this opportunity. Can you see my screen, and am I audible?
Yes, sir. Yes, sir.
Okay, so now moving on to this rare subset of the tumors, which is thymoma and thymic carcinoma, I'm going to touch on the pathology, classification, and ISCs. So as we know that the thymic tumors occur in the mediastinum, and in addition to the thymic tumors, a wide variety of other tumors also are seen in this region, and classification is decided based on the location. But still the thymomas and thymic carcinomas, they are the predominant tumors in this region, especially in the adults as compared to in the children, where the lymphomas and germ cell tumors are more common. Coming to the classification of these tumors, now the WHO recently has made it very simplistic, and we have two subgroups, mainly the thymic epithelial tumors and thymic neuroendocrine neoplasm. And in thymic epithelial tumors, thymomas and thymic carcinomas are and which includes their various subtypes, which I'm going to illustrate in subsequent slides. So before we go into the thymomas and thymic carcinoma, let's recapitulate our understanding about the normal thymus, which is very much important to understand the biology of this tumors occurring in this region. So normal thymus, it is a lymphoid-rich organ, and which composed of epithelial cells as well as the dense lymphoid cells, and it has two regions, that is cortex and medulla. So cortex is predominantly more rich in the lymphoid cells as compared to the medulla, which is relatively pale area, which shows Hazel's corpus and more of epithelial cells. And not even the proportion of epithelial and lymphoid cells are different in these regions. Even the ISC profile of these cells are also variable. So which these helps, like in the cortex, we do the cortical lymphocytes, they are TDT positive as compared to the medulla, which is negative for TDT and CD1A. So these helps us to understand the biology of the tumors. And even the epithelial cells are more of epithelioid in the cortical region, whereas they are spindle shaped in the medullary region. So the classification of the thymic epithelial tumors, they are classified based on the various histological features, and we have two subgroups, thymomas and thymic carcinomas, depending upon the which predominant cell type, and that's why there is a lot heterogeneous spectrum of these tumors we see, and they are staged based on the extent of the invasion, lymph node involvement, and spread to the various structures. And there are various staging system also adopted, which as a pathologist we have to comment in the resection specimen to decide the adjuvant therapy. We have to keep in mind that thymomas, although earlier it is presumed that they are benign, but they are potentially malignant, and irrespective of the type of thymomas, we have to consider them malignant. So the evaluation of the classification of the thymomas, we have seen a lot of changes occurred, especially in the 90s. But recently, now at least in the last two decades, WHO has come to a standard as uniform classification of thymoma and thymic carcinomas, and they are categorized into the thymomas type A, AB, B is further subdivided into B1, B2, and B3, and thymic carcinomas. So there are earlier the B3 was considered to be thymic carcinoma. So now it is uniformly understood that B category is divided into 3 subsets, and thymic carcinoma is a separate subset, and which is also accepted in the recent classification. About the staging of the thymoma, the classification system which was widely used is the Mashoka-Kaga staging system, and but recently even that there are subtle differences in this systems as compared to the TNM staging. And if you see in the TNM 8 staging, there are some categories which were earlier put into the stage 1, stage 2, and stage 3. They are all now lumped into the stage 1A. So there are subtle differences between the classification in the staging parameters. So we have to specify which staging system we are using, and I prefer we should mention both the staging system in your reports. So next is about how does these the classification of thymomas impact on the staging. So if you see the early stage tumors, that is stage tumors, they are predominantly they are type A thymomas, and whereas in the thymic carcinomas we very rarely see the early stage cancer, and that's also applies to the as we move from the B1 to B3 thymomas. Let's move to the gross appearance or histology of these tumors. Thymomas, usually they are the lobulated, well circumscribed tumors, but as compared to if you see the gross appearance of a thymic carcinoma, it can show the variable appearance as similar to any carcinomas with the areas of necrosis and hemorrhage. Classification, how we categorize them. So it is based on predominantly on the which component is predominant, whether it is epithelial predominant component or a lymphoid predominant component. So if it is a epithelial predominant component, then it will be either type A thymoma or type B3 thymoma, because they show the less number of the lymphoid cells. But if the lesion is rich in the lymphoid cell, then it is likely to be B1 or B2 thymomas. So this is the histological spectrum which we see across all these thymomas, and I will illustrate some of these examples. Type A thymoma, that is also previously called as a medullary thymoma. It is composed predominantly of spindle cells, but we have to keep in mind it can show the various histological patterns, so it can become challenging, and you will not always see the spindle cells on the morphology, and sometimes we have to use the ISS to differentiate it from the SFT or other spindle cell tumors. Thymoma type B1, they are predominantly lymphoid rich, and they resemble the normal thymic tissue. And in these thymomas, there can be some pale areas which are medullary islands, and you will see very rarely, or we find it very difficult to identify the epithelial cells on the routine microscopy, and only with the help of ISCs, these epithelial cells which are highlighted by this CK19 will become prominent, and you will otherwise you can end up calling this this lesion as a acute lymphoblastic lymphoma. So ISC for cytokeratin is very much important to distinguish B1 thymoma from the lymphomas. B2 thymomas, here the proportion of epithelial cells increases as compared to the B1 thymoma, and we are able to identify these cells more clearly. And if you start seeing the clustering of these cells, then the diagnosis of a B1 thymoma is unlikely. So moving on to the if you see the mixture of A and B, that is called as AB thymoma AB, in which the pink looking areas are of type A, whereas the other area is of type B1, and each component should be of at least 10% to give a conclusive diagnosis of thymoma type AB, which may or may not be possible, especially on the biopsy, and the diagnosis can be comfortably given only on the resection specimen. Thymoma type B3, here you will see more atypia, but it is not sufficient to put it into the diagnostic category of thymic carcinoma, and the TDD positive lymphoid cells are less than 10%. So although these are the diagnostic categories, but we can sometimes get more than the thymoma which is more than of one type, and in this situation we have to give the percentage of each component of thymoma. And besides the classification of thymoma, the comment on the capsular invasion is very much important. So for that we have to sample the areas which are from the periphery of the tumors, so that we can make a conclusive diagnosis of thymoma, as well as can comment on the resection status. The problematic areas which in the diagnosis of the thymomas are the areas which can be of borderline cases, and the thymomas which has high mitotic activity or more atypia or necrosis. So in those situations, ISC helps to resolve these problems, and TDT and A1, A3 are the markers which are commonly used which can assist in the diagnosis. And for the diagnosis of thymic carcinomas, these are the few markers which assist in distinguishing the thymomas from the thymic carcinomas. So if we have to use the ISCs, there is a list of the ISCs which we can use. Cytokeratins help to distinguish not only the thymomas from its subtype, but also help to distinguish it from the common lesions, that is a lymphoma, because the diagnosis and the treatment is completely different. For thymic carcinoma, CD5, CD117, they are positive in thymic carcinoma but negative in thymomas. And this is how the meshwork of a thymoma can vary across the various histological subtypes, as it is a loose meshwork in B1 thymoma, whereas in B3 thymomas it is a very nice striking meshwork. So also with the help of basic ISCs, we can distinguish these thymomas. Another ISCs which can be used for distinguishing the thymomas, that is a TDT. So based on the proportion of the TDT positive cells, we can distinguish type A thymomas from others. So if you see even in the biopsy specimen, if TDT positive cells are more than 10%, then it is likely to be either AB or B thymoma rather than type A thymoma. Next, even there are some thymic or compartment specific antibodies, but they are not commonly used, but these options are also available for diagnosis. Another diagnostic challenging category is the thymoma which shows some atypical features, maybe in the form of necrosis or increased mitotic activity. So there is a new diagnostic term which has been put in the WHO, that is a atypical thymoma for this. So these cases morphologically still they are thymoma, but not sufficient to label them put into the diagnostic category of thymic carcinoma. And finally, about the thymic carcinomas, we can see a lot variety of thymic tumors in thymic carcinomas in the thymic regions, and the diagnostic criteria for them, there should be a clear-cut atypia, and there should be exclusion of metastasis to the thymus from the other sides. And the ISC for CD1 and CD117 can help to support the diagnosis. So it is very much important to distinguish between the thymoma and the thymic carcinomas. But if we come, which is most relevant from the treatment point perspective of, it is not the histological subcategory, but it is the whether it is a thymoma, thymic tumor is infiltrating the surrounding structure or the capsule. So if it is going beyond the capsule, if irrespective of the histological subtype, the clinician will offer the adjuvant radiation or any therapy, and all thymic carcinoma do require postoperative therapy. So this is the summary of diagnostic algorithm for thymic tumors and thymic epithelial tumors. So we do have to apply the WHO classifications, in which now the recent WHO classification, they have mentioned about the essential and desirable criteria. So the subcategorization of thymomas will be easy in future, and if there is any ambiguity in the diagnosis, the IHC should be used for the for definitive diagnosis. With this, I end my talk, and if I have 30 seconds, I'd just like to touch up. Can I touch up on the molecular aspect? Just 1 or 2 slides.
Yes, sir. Yes, sir.
Sure, sir.
Although till date we make a diagnosis based purely on the histological features or use of some additional ISCs, but now the molecular workup is also coming into play in the thymic tumors, and based on some genomic analysis, it has been now presumed that thymic tumors can be categorized into the four subgroups, and which have a distinct molecular profile, especially the thymoma type A and AB. They show this unique GTF21 mutations. So these markers, and now even the immunohistochemistry is being developed for these for this mutation. So maybe in future we will be able to categorize these thymomas not only on the morphology but also using these molecular subtypes. So if with this I end my talk. If there are any questions, I'll be happy to take them.
Thank you, sir. Thank you for your elaborate discussion on this topic. We always have some confusion regarding the pathology of this rare tumors, but you described it very nicely and comprehensively. After this talk, we move on to our next talk. For that, I invite Dr. Prashant Penumadu, sir, who is additional professor and head of department at JIPMER Pondicherry, and he would be discussing about the role of surgery in thymoma and thymic carcinoma. Over to you, sir. Sir, you are muted.
Yeah, am I audible?
Yes, sir.
Yeah, thank you. Thank you. Good evening, and thank you very much for the opportunity. Over the next 10 minutes, we will look at the surgical management of thymoma and thymic carcinomas. Dr. Rajiv has very nicely brought about the pathology, because pathology plays a very important role in your decision making regarding the role of surgery. I will not get into the slides again. But just for the next few minutes, I will take you all through what thymoma is all about and what is the role of surgery. Are my slides moving? Yeah. So thymoma is the most common anterior mediastinal tumor, and we know that it constitutes about 20% with an age common between 40 to 60 years, and male to female preponderance is about 1:1. The most common presentation that we see are either because of an incidental diagnosis on routine chest X-ray, you find a mediastinal mass and then you pick it up and then further evaluate, or local symptoms. Unfortunately, the tumor must have been very aggressive by the time, and paraneoplastic syndromes. There are multiple paraneoplastic syndromes where myasthenia gravis is the most common paraneoplastic syndrome seen. Diagnosis, CT is the gold standard. A good contrast enhanced CT is the gold standard. It based on the radiological findings, you would actually identify anterior mediastinal masses, and most of the times a biopsy is not required to go ahead with the management for well encapsulated. But if you have any suspicion that it's not looking like a thymoma, or you have a borderline or an inoperable patient, then a biopsy is mandatory. MRI is very rarely indicated, only in the upper when you have loss of planes with brachiocephalic, or you want to do extensive, you're doubtful about the indication. And role of PET is controversial, wherein, you know, most of the things can be picked up with the CECT of the thorax and the upper abdomen, even with the metastatic sites, if at all, because you mainly want to rule out an extrapleural disease. So now coming to the treatment, we have stage 1 and stage 2. Undoubtedly, we know that the treatment of choice is surgery. For stage 3 and stage 4, we will still look into it. Surgery still remains, but with some form of multimodality treatment, which will be covered in the next topic. So the extent of surgery, there's always a debate whether you should do a total thymectomy or a partial thymectomy. So what do you mean by total thymectomy? Total thymectomy is removal of the entire fibrofatty tissue of the anterior mediastinum. That's the entire thymus gland, along with the 2 cervical horns from phrenic to phrenic, and the entire fat reaching till the diaphragm. So this is a total thymectomy. It is possible, and partial thymectomy is another option. When you should do. So for a patient with myasthenia gravis, there is no role for partial thymectomy. But it is feasible in patients those are non-myasthenic, because it has shown no difference in survival or recurrence rates. And also the rates of developing myasthenia later is also similar. Of course, the first and foremost thing that we need to remember here is there are no randomized controlled trials in this disease to say that this is better or that is better. Most of the series comes from the retrospective series, and the largest is one of the series from Japanese series. So now coming to thymoma and myasthenia, we know that myasthenia is seen about 50% of the patients with thymoma, but only 10% of myasthenia have thymoma. This is something that which we need to remember. And surgery for myasthenia gravis, that is thymectomy, is not an emergency surgery. Patient should be adequately controlled with drugs, with pharmacotherapy before you take up the patient for surgery. This is something that which I want to stress upon. Then, regardless of the antibody status and myasthenia type, in thymoma, if there is a thymoma, surgery remains the treatment of choice, and definitely it reduces the pharmacotherapy. However, in a non-thymoma, the surgical treatment purely depends on the antibody status, whether it is generalized or ocular, and the patient's age. So this is a very interesting chart which I've taken from UpToDate. So once you confirm the antibody status, and then the initial evaluation and management, as I said, is with pharmacotherapy and with AC inhibitors with or without for control of symptoms. And then let us say if it shows thymoma, go ahead. If it does not show thymoma, look for MuSK or LRP for antibody associated myasthenia. And depending on whether it is yes or no. If it is yes, then there is no role of thymectomy. If not, or if the patient is having generalized myasthenia or an ocular myasthenia with debilitating symptoms, then the age factor comes into picture. Anybody less than 50, thymectomy would definitely help. More than 65, there is no role of thymectomy. And 51 to 65 is the age group where you have to take a call for thymectomy, but defer thymectomy as long as possible to continue response to pharmacotherapy and then take a call. So this is a very good flowchart to decide on patients with myasthenia gravis and those who are whether thymectomy would help or not. Now, what is the surgical approach do we have? Median sternotomy by far is considered the gold standard, and to achieve access for both thymectomy as well as extended thymectomy. But what is the problem? The inadequate surgical access sometimes to the upper and lower chest if you have extensive disease. So for these structures which are involving hemiclamshell is a very useful approach when they involve the adjacent structures. So this was first reported by Masoka for cervical as well as mediastinal or cervicothoracic. And when it invades the great vessels in the neck, so such as the brachiocephalic or a median sternotomy with transmanubrial osteomuscular sparing approach is also useful to achieve a complete resection. So is minimal invasive surgery for thymus safe? What are the approaches? We can either approach the thymus. Generally, the golden principle is approach the thymus from the thymectomy, where the thymoma side is, because you have a good control. But in case if there is no thymoma, the choice is definitely left whether you want to approach from the right side or left side. And it is surgeon's choice. And bilateral VATS, because putting a camera on the opposite side also helps you identify the phrenic nerve and preserve, because phrenic nerve preservation is something which is very, very important in patients with myasthenia. The other approaches are subxiphoid or a single port subxiphoid or a robotic thymectomy. The advantages with VAT thymectomy is generally carbon dioxide is used, and it actually makes you help in dissection of the cervical horns, which actually makes it much easier. And you know that the recovery in these group of patients with the minimal invasive surgery is important. But mind you, the extent of surgery will not change whether it is a minimal invasive surgery or an open surgery. So similarly, whether robotic or when manual invasive, there are no comparison trials, but then they found that lesions more than 5 centimeters are not appropriate for minimal invasive. But however, there are series which shows even up to 8 centimeters can be safely handled by means of minimal. And the other important thing which you need to take into consideration is avoid tumor rupture or capsular breach. So that unnecessarily upstages the tumor and you may have to give adjuvant radiotherapy. Unfortunately, the data may not be very strong, but then you are upstaging the patient if you cause a capsular breach. So extended thymectomies, yes, feasible, possible when you have mediastinal structures involved. You could go ahead and do a pleuropneumonectomy if required, reconstruction of the SVC or the brachiocephalic, or depending on whatever have been reported safely by several authors in this group. And the key for surgery is to achieve an R0 resection. So for patients who are locally advanced, you use the extended surgeries, but after some form of neoadjuvant chemotherapy, wherein you would have a role for cytoreduction or debulking the tumor and then taking a call. So aortic arch involvement, these are others. So, and remember, when phrenic is involved, do not try, and when it's grossly involved, it needs to be, but also make sure that you take care of the diaphragm so that to improve the postoperative pulmonary function. Now, recurrent diseases, there are no standard guidelines to what exactly should be done, but from, the recurrences were about 14.8% from one of the series from Japan, and most of them are pleural. So recurrence diseases, whenever and possible salvageable by surgery, should be salvaged because they are known to have a better prognosis when compared to not doing anything for this group of patients. So how do you manage pleural disease? So most of the times, thymomas and thymic carcinomas with high rate of locoregional tend to have very poor prognosis. So the 5-year survival rate is about 53 to 87%. And the treatment in this group of patients is very controversial. So the most important key is maximal tumor debulking with aggressive local therapy could offer, and also systemic therapy for sure. Despite that, your recurrences are very high, and combination of cytoreduction with concurrent chemoradiotherapy or is the gold standard as of now. So there is a new kid in the block, let's say hyperthermic intrathoracic chemotherapy. The role is not very clear, but there are additional studies which have looked at the basic principle is the local therapy. The chemotherapeutic agents are high doses can be achieved with minimal absorption. So systemic effect is less. But however, macroscopic complete tumor resection is the key, and cisplatin-based regimens are more commonly used. It has shown some promising survival and disease-free survival in low-risk epithelial malignant pleural mesotheliomas. But its role in thymic tumors is still controversial. So these are some of the studies where they have looked at, and they have shown a promising recurrence-free as well as survival, overall survival. But mind you, the number of the patients will always be smaller numbers because this is not that common. So the perioperative outcomes are not different. They show that pleural, the toxicity related is about, postoperative renal fail is predominantly depend on the cisplatin dose. But however, the other morbidities like in-hospital mortality and the outcome is more or less similar, but definitely needs more robust studies. To conclude, surgery remains the primary treatment of choice for thymoma and thymic carcinoma. Maximal cytoreduction is the key in advanced stages. Avoid tumor spillage in early cases. It definitely worsens outcomes. Surgical CRS with HITOC offers encouraging survival rates, but cannot be done outside experienced centers. It has its own morbidity. Both primary and secondary, that is pleural recurrences, stage 4 should be offered surgical treatment at some point of time whenever operable. Safe and feasible in selected patients with thymic malignancies and pleural dissemination. Thank you, and I would be happy to take any questions.
Thank you, sir. Thank you for such an extensive and a comprehensive discussion about the role of surgery in thymoma and thymic carcinoma. Sir, is there any role of debulking if tumor is unresectable, patient is very symptomatic,
Yes, Amit. There is definitely a role of debulking if in patients who are completely unresectable to. There is a role, but preferably after some form of multimodality treatment. Going upfront and debulking may or may not be a great option, but definitely after some form of neoadjuvant or in the upfront treatment, and then that would really make a lot of difference.
Okay, sir. Okay. Thank you so much, sir.
Yeah.
Now we move to our next talk that will be delivered by Dr. Vikas Talreja, sir, who is consultant Department of Medical Oncology at Regency Hospital, Kanpur, and he would be discussing about the role of chemotherapy in management of thymoma and thymic carcinoma. Over to you, Vikas, sir.
I hope my screen is visible and I am audible right now.
Yes, sir.
Perfect. So we'll start the presentation for the thymic carcinomas, the chemotherapies. And I believe it was a very brilliant session so far now with an extensive discussion on the therapies that are currently available. Yeah. Perfect. So thymomas, as we know, these are the most common tumors of the anterior mediastinum, and the incidence is 15 cases per 1 lakh population, seen in 40 to 70 years of age group. These are biologically aggressive tumors which are capable of local invasion and metastasis. 90% occurs in the anterior mediastinum, rest occurs in the neck or the other mediastinal areas. Well-known association with myasthenia gravis. As we know, thymomas are good biological tumors with a 5-year survivals of around 90% as compared to thymic carcinomas, where 5-year survivals is 55%. There are multiple paraneoplastic syndromes associated with it, the myasthenia gravis, the red cell aplasias, the hypogammaglobulinemias, the neuromuscular symptoms, myotonic dystrophies, myositis, Lambert-Eaton syndrome. So myasthenia gravis, as we know, is those occurring in young females and older men, usually female to male ratio is 2:1. Antibodies to the nicotinic acetylcholine receptors. The mechanism is an autosensitization of the T cells of the thymic hormones. Treatment is iridostigmine, plasmapheresis, thymectomy. And red cell aplasia, as we know, is occurs in 5% of the patients with thymomas, with red cell aplasias in 30 to 50% of those having associated thymomas. 40%, more than 40 years, 96% do have the common association with it. And the bone marrow examination reveals an absence of erythroid precursors. Thymectomy has produced remissions in 38% of these cases. Hypogammaglobulinemia is known as the Good syndrome. Again, has 10% association with it, recurrent sinusitis, defects in both cellular and immune immunities, and also associated with red cell hypoplasias. Thymic carcinomas and thymomas are usually diagnosed by invasive imaging modalities like CT and MRIs. PET scan shows a decreased uptake in 56 patients, and we usually do since these are mediastinal tumors, we have to rule out the mediastinal germ cell tumors, the LDH, AFP, beta HCGs. These are negative. So that's how you call thymomas when they are well-defined mediastinal masses, not continuous with the thyroid gland, AFP and beta HCG negative. And the staging has been extensively discussed. We will divide the staging in terms of stage 1 and 2 management and stage 3 and 4. Stage 1 and 2 is usually surgical game, most important predictor for the long-term cervicals. Median sternotomy is the most commonly used process. Clamshell procedure, as you could see, the mortality is less than 3% in experienced centers. Extended total thymectomy includes all tissues anterior to the pericardium from the diaphragm to the neck and phrenic nerve. If it's a stage 1, no post-op radiation is required. If it's a stage 2, no post-operative radiation is required in most patients, but those with an R1 resections or high-risk features such as high-grade or a larger tumor size may require like a 50-grade radiation, so with the closed margins, 54-grade for a positive margins. For stage 3, stage 4, we should attempt a debulking or complete resection if possible. If it is not possible, then radiation has high rates of local recurrence that may be improved with the use of the post-op radiations. Patients with high-risk features will more likely to benefit. With stage 4, it's palliation of more symptoms. For those where we deem it to be intermediate between resectability and unresectability, that is potential resectable, neoadjuvant chemotherapy and post-operative radiation is indicated in tumors with invasions with pericardium or lung or with great vessel invasion. Tissue diagnosis is needed to start the therapies after neoadjuvant surgery is there. Completed resection should be followed by adjuvant radiation because of the risk of recurrence. If complete resection is not possible, maximum debulking surgery followed by post-operative radiation. And that's where, even though we don't have a randomized trials, but then again, there is a benefit of undergoing debulking surgery with an hazard ratio of around 50 for these patients. So neoadjuvant chemotherapy, combination chemotherapies followed by radiation also offer chance of prolonged disease-free survival in potentially patients who are not resectable. A meta-analysis of an induction therapies for advanced thymic epithelial cancers has shown that there is a pool rate of complete resection of around 73% with a response to induction chemotherapies with 59% and a 5-year and 10-year overall survival rate of 87 and 76% respectively. So you can't have a randomized trials for it, but yes, there is a lot of pooled evidence and pooled data for it. And most of these do tend to have myasthenia gravis or hypogammaglobulinemias or pyorrhoid cell aplasias as a therapies, as a paraneoplastic syndromes. And the most of the commonly used regimens across, you can find a lot of cisplatin based regimens. So the basic denominator is the cisplatin based induction regimens. With the backbone of the platinums, you can add the etoposide, you can use docetaxels. There is doxorubicin, vincristine, cyclophosphamide, like a CHOP regimen with prednisolone regimens, and then there's doxorubicin, cyclophosphamide, prednisolone. So all of these have demonstrated a good response rates across the subgroups. And if you look at these, the pool response rate is around 50 in the hazard ratio of 0.59. And the pool rate of complete resection after the induction therapy is around 0.73, the hazard ratio, and the pool odds ratio of response to the complete resection is 1.4. Again, 5-year overall survival rate have a significant effect as compared to with the induction chemotherapy. 10-year overall 0.76, and those who underwent a complete surgical resection after the induction chemotherapy has a significant 5-year and 10-year survival rates. So stage 4 tumors, 36%, stage 4B, again, rare entity. So there are favorable rates for long-term survival with advanced disease who underwent induction chemotherapies and surgical resections. Unresectable disease, it could be anywhere across. So the various suggested regimens includes the CAP regimens, the cisplatin, doxorubicin, cyclophosphamide, with a complete response rate of around 10% and an overall response rate of 50%. The CAP with prednisolone, 100 milligram, like a CHOP regimen, again has an overall response rate of 77%. The ad hoc regimen where you use cisplatin, doxorubicin, vincristine, cyclophosphamide, again has a complete response rate of around 43% with an overall response rate of 92%. The PE, that is cisplatin etoposide, the EORTC study showed a complete response rate of around 31% with a median PFS of 2.2 and OS of 4.3 years. The VIP regimen used in the mediastinal germ cell tumors has a 32% partial response rate. Paclitaxel, bread and butter are usually sometimes the preferred regimens. The 43% response rate is again a good tolerable regimen in case you have a resource constraint for the cisplatin or cisplatin eligible patients. Second line, a number of agents has been used: etoposide, ifosfamide, pemetrexed, octreotide, 5-fluorouracil. Now, there is a very good evidence since they express EGFR, so they have a pan-TKI has been used. Sunitinib has been used in the thymomas and thymic carcinomas, and you could see that there is a good demonstrable partial response rate around 26% and 65% to 75% stable disease rate. And sunitinib, as we know, has a good range of toxins associated with it. The mTOR inhibitors are also good ongoing treatments. Somatostatin receptors are present in it, and somatostatin receptor antagonistics, octreotide, has been tried in many of these patients and has shown a durable response rate. Again, EGFR has a very high expression, but not again much role here, not much success with the anti-EGFR therapies there. A lot of these patients, because of the radiations, because of the chemos being following thymectomy, have a secondary primary cancers, B-cell non-Hodgkin's lymphoma, GIST, and soft tissue sarcomas. And therefore, NCCN does recommend it after the surgery or after radiation, a CT scan every 6 months for 2 years, then annually 5 years for thymic carcinomas and 10 years for thymomas. And for those who have recurrent disease, follow-up for at least 10 years should be there after the initial induction treatment has been done. Even if it's a surgery, there is a risk of a drop pleural metastasis in them. We have a very good Indian data from around 62 patients with a histopathological confirmation of thymomas who were given a planned dose of radical intent radiation with 60 gray and a palliative radiation across the subgroups with a median overall survival of around 16 months. And the prognostic factors depend upon the type of the tumors, the stage of the tumors, whether they were resectable or unresectable, and whether what type of therapies was used. So in Indian data, myasthenia gravis was seen in 15% of patients, and 40% resectability was seen after the neoadjuvant chemotherapies. So thymic carcinomas and thymomas, again, paraneoplastic syndromes are rare in thymic carcinomas. In thymomas, it is common. Prognosis is good for thymomas, worse for thymic carcinomas. Chemotherapies is capped for thymomas, PEC recover for thymic carcinomas, and 5 years surveillance for thymic carcinomas, and thymomas 10 years. So again, thymic carcinomas, carcinoid chemotherapy rarely has been used. 5 years survival around 60%. If you achieve a complete resection, long-term survival is poor and is correlated with the extent of the disease and the degree of the tumor differentiation. Thymolipoma, again, treatment is complete surgical resection, and that's how to summarize it. Stage 1, total thymectomy. Stage 2, radical surgery followed by radiation. Stage 3 or stage 4, give a potential benefit of induction chemotherapies. If it goes to the surgery, then you can consolidate with the post of radiation. If it's in metastatic, then we have discussed a lot of options. Thank you. Lovely concept, and I must congratulate the organizers. Over to them. A wonderful.
Thank you, sir. Thank you for nicely describing all the details about chemotherapy regimens in thymoma and thymic carcinoma. Now we move ahead to our next talk, which will be delivered by Dr. Anil Tiblewal, sir, who is the radiation oncologist, assistant professor at Tata Memorial Hospital, Mumbai. He would be discussing about role of radiation in thymoma and thymic carcinoma. Over to you, sir.
Hi, good evening, everyone. So I'll be speaking on the role of radiation in thymoma and thymic carcinoma. So I'll not go into the details about the incident. Hello. Yeah, so I'll not go into the details of. So may I continue? Hi. Anatomy-wise, thymoma or the thymus in Greek is meaning the heart. So due to its location, it's pinkish gray, soft lobulated and firm, encapsulated, located in anterior square mediastinum in front of heart and behind sternum. And the upper pole may extend up to inferior border of thyroid, whereas lower pole can go as far down as diaphragm. This needs to be remembered from the radiation oncology point of view, because to delineate the clinical target volume, the anatomy is very important. And we all have heard that the thymoma and thymic carcinoma are rare tumors. The thymoma, the incidence according to the SEER database is 0.15 per 1 lakh population, and thymic carcinoma is still rarer than the thymoma. They are associated with multiple paraneoplastic syndromes. So these were the initial, I can call it, so one of the initial Masoka Koga staging system, which was published in 1981 and later modified by Koga. And and became famous as the modified Masoga-Koga staging. Here, the important point to note here is stage 2A is macroscopic transcapsular invasion, and stage 2B is the macroscopic invasion into thymic or surrounding tissue, or grossly adherent to but not breaking through the mediastinal pleura or pericardium. These are important because a lot of things will depend upon the staging of the thymoma or thymic carcinoma. There were many confusion regarding the pathology, as Dr. Raju has already clarified. I will not go into the details of this. And very recently, the AJCC group has proposed that for thymoma and thymic carcinoma, we should use the TNM staging 8th edition. And they have also classified into T1A, T1B, T2, T3, T4, N0, N1. So thymoma rarely metastasizes to the regional lymphatic, M0 and M1 as defined in the Masoga-Koga staging system, and the stage grouping also. So this is important as far as the adjuvant therapy is concerned. Type A, AB, B1, B2, and B3, and recently 5th edition of the WHO classification also retained this classification because these are very important as far as the prognosis of thymoma are concerned. When we look at historically, the important prognostic factors across all the studies are the three most important. One is this: the staging, and the completeness of surgical recession, and the pathological histological classification. Staging is the most important, then the completeness of recession, and then the histology. So what is the role of radiation in thymic tumor? The most important and most common indication is the post-operative radiation therapy after the surgery in thymoma as well as in thymic carcinoma. Rarely in locally advanced or unresectable, so thymoma and thymic carcinoma, radical CTRT is given. An experimental basis neoadjuvant approach in locally advanced or unresectable thymoma or thymic carcinoma. Now, I will most likely will discuss the evidence for the role of post-operative radiation therapy in stage 2 to stage 4 thymomas, because these are really gray areas because there are no prospective randomized control trial or no prospective studies. Majority of the evidence is solely based on the retrospective studies. So let's first look at the SEER database published by Wessler et al. In thoracic surgery in 2012, 476 patients of completely resected stage 3 thymoma. Here you can see the surgery plus post-operative radiation therapy versus surgery alone. Post-operative radiation therapy improves the overall survival. You can see 10-year overall survival is 55% with the surgery and PORT as compared to 40% with surgery alone. So here they have concluded that PORT did improve the overall survival. However, on multivariate analysis, the PORT did not improve the overall survival. Now, when we look at the International Thymic Malignancy Interest Group, their retrospective database in completely resected stage 2 and stage 3 thymoma, they have also documented that the 5-year overall survival as well as the 10-year overall survival is much better as compared to surgery alone. So post-operative radiation therapy improves the overall survival in stage 2 and stage 3 thymoma. Now, when we look at the Japanese data shows that the post-operative radiation therapy did not improve the relapse-free survival in stage 2 as well as in stage 3 thymoma. So here there is a conflicting evidence that the PORT did not improve the relapse-free survival in stage 2 and stage 3 thymoma. However, in thymic carcinoma, the PORT indication in stage 2 and stage 3 thymoma is retained, and they improve the relapse-free survival in both stage 2 and stage 3 thymic carcinoma. Now, to a larger cohort, when we look at the National Cancer Database of approximately 4,256 patients, so which have included stage 1 to stage 4, they have concluded that the post-operative radiation therapy did improve the overall survival. However, if you see stage 1 to stage 2A, there is not much of a difference in overall survival when we give PORT or when we don't give PORT. However, in stage 2B and stage 3, the PORT did improve the overall survival, and it was significant in multivariate analysis also. So maybe in stage 2A, we should not offer the PORT. Now let's look at the guidelines or the post-operative radiation therapy in thymic carcinoma. The meta-analysis also suggested that the PORT improved the overall survival. Now, when we look at the NCCN guidelines, this is the Indian Cancer Experience, so which has been elucidated by Dr. which has been elucidated by Dr. Vikas already NCCN guidelines in resectable thymic tumors, they have shown that in stage 1 thymic in stage 1 thymoma or thymic carcinoma, there is no role of PORT or chemotherapy. However, in stage 2 to stage 4, they have recommended to consider the post-operative radiation therapy. In R1 and R2 recession, we should definitely consider the post-operative radiation therapy plus minus chemotherapy depending upon the indication. So here, stage 1 thymoma, no role of PORT. In locally advanced and unresectable thymoma, thymic carcinoma, if it is completely unresectable, then concurrent chemoradiation. However, if it is potentially resectable, then the approach of trimodality with neoadjuvant chemotherapy. If it becomes resectable, then surgery and then followed by postoperative radiation therapy. If it is unresectable, even after neoadjuvant chemotherapy, then the radiation therapy plus minus chemotherapy has been recommended by NCCN guidelines. Now, when we look at the ESMO guidelines, so ESMO guideline also recommend that in stage 1, the role of PORT is not recommended or not beneficial. In stage 2A, in the pathological classification of A, AB, B1 and B2, the role of PORT is not recommended by ESMO guideline. Only in B3 histology in stage 2A, they have recommended the PORT. In stage 2B, only B2 and B3 have been recommended for PORT, and all stage 3 thymoma and thymic carcinoma has been recommended to administer PORT. In all R1 recession, irrespective of the pathological type, we should deliver post-operative radiation therapy. When we look at the thymic carcinoma, then only in stage 1, the PORT is not recommended. In stage 2, they have said that it should be considered. And in stage 3 and stage 4A, they have said it is recommended to offer PORT in thymoma and thymic carcinoma patients. Now, when we look at the radiation planning in thymoma and thymic carcinoma, it is very important for the radiation oncologist to discuss, and communication should be maintained with the surgeons regarding the operative finding, what were the difficulties that the surgeon encountered while doing the surgery, so that they could help us to define the clinical target volume. It is important because the post-operative radiation therapy will decrease the recurrence rate, and if we define our target volume properly, then only it is beneficial. Otherwise, we are not going to do any benefit as far as the thymoma is concerned. So we should also chew our head of our pathologists regarding the histology, because histology matters a lot. And extracapsular extension, so whether there was any extracapsular extension focally or grossly, and the surgical margins, whether they were free or closed, or whether there is any doubt about the surgical margins in the mind of the surgeon as well as the pathologist. So communication with the surgeon and pathologist is very important. And here comes the multidisciplinary tumor approach, because only to refer the patient for post-operative radiation therapy without giving complete idea is not going to help from the radiation oncology point of view. And we should also review the pre-operative imaging. So because a lot of information will be there in the pre-operative imaging, and co-registration of pre-operative imaging with your planning CT is important. As far as the radiation delivery technique, the minimum requirement is the 3-dimensional conformal radiation therapy and IMRT, because so this will give a lesser toxicity as compared to conventional cobalt, and these patients are going to survive for a long term. So we need to reduce the toxicity as much as possible. The radiation therapy doses are pretty standard for adjuvant radiation therapy, 45 to 60 gray, depending upon R0, R1, and R2. And in unresectable radical RT, then the dose should be 60 to 66 gray in 30 to 33 fraction. Elective nodal irradiation is not recommended for thymoma as well as in thymic carcinoma. So this is the neoadjuvant approach, so which was evaluated in a single-arm pilot study of 22 patients. They had delivered neoadjuvant chemoradiation therapy to a dose of 45 gray, and they have shown that out of 22 patients, 17 had R0 recession. But this is still purely experimental basis, and a larger database is required to implement this into the routine clinical practice for locally advanced or unresectable thymoma, thymic carcinoma. So my take-home message will be that thymic tumors are generally rare, and we should adopt a multidisciplinary tumor board discussion. So because a lot of the patient will require the post-operative radiation therapy plus minus chemotherapy, and complete surgical resection is the cornerstone of the management of thymoma and thymic carcinoma. Post-operative radiation therapy is indicated in all patients with incomplete recession and stage 2 to stage 4A thymoma, but it should be individualized, so depending upon the pathological classification. In thymic carcinoma, except stage 1, we should offer postoperative radiation therapy plus minus chemotherapy for stage 2 to stage 4 thymic carcinoma. So this is my last slide. I'll be happy to take questions if there are any.
Thank you, sir. Thank you for your elaborated discussion about role of radiotherapy. Currently, there are no questions in chat box. So we move on to our next talk. This is actually a panel discussion, and panel discussion about management of thymoma and thymic carcinoma in general. For this, I would request Dr. Amit Kumar, who is consultant medical oncologist at Medanta Cancer Center, Patna, to moderate this session. I would also like to invite our esteemed panelists for this panel discussion. Dr. Somnath Roy, who is medical oncologist from Tata Memorial, Tata Medical Center, Kolkata. Dr. Tripti Pai, madam, who is consultant Department of Pathology from Tata Memorial Hospital, Mumbai. Dr. Sarvana R is busy with some emergency, so he will be unable to join. I would request Dr. Prashant Penumadu, sir, if he can help us to join this discussion, to complete the discussion. I would also request Dr. Anil Tiblewal, sir, to join as a radiation oncologist for this discussion. He is a consultant radiation oncology from Tata Memorial Hospital, Mumbai. And another panelist is Dr. George Abraham, who is assistant professor medical oncology at RCC Trivandrum. So now over to Dr. Amit Kumar, sir, for this panel discussion.
Yeah, thank you, Amit, for this opportunity. And till now, what we have discussed about thymoma, I think most everything has been covered. A very nice presentation by Dr. Rajiv sir, and then by Dr. Prashant sir, and Dr. Anil has covered all the radiotherapy part, and Dr. Vikas too has left nothing back. So we will just have an overview and a simple discussion about the management of thymoma in routine clinical practice. So I'll just give a clinical scenario, and based on that, we will have a short discussion. So coming to this is a 45-year-old lady without any comorbidities. She presented with a complaint of dry cough for around 3 months and hoarseness of voice with shortness of breath for 15 days. There was otherwise no history of any fever, hemoptysis, or bleeding manifestation to this mission, and she hasn't received any blood transfusion too in the recent past. On evaluation, she was a ECOG PS2 with no pallor cyanosis, no lymph nodes was palpable, but there was a facial puffiness with McWinsberg gauze, though the otherwise chest, CVS, and per abdomen were mostly normal. The initial investigation the patient showed is about normal hemoglobin for this, with a normal differential count. LDH is 2 in the normal range. The CT is showing a soft tissue dense mass, which is a homogeneous with central necrosis in anterior mediastinum, extending from something around level of manubrium to right atrium. Size is 12.3 into 6 into 10 centimeter, and it is abutting the left brachiocephalic vein and SVC, but maintaining the fat plane with ascending aorta, with focal loss with pericardium, and coarse calcification was noted within the mass. Otherwise, the lung parenchyma was normal, no pleural effusion, no involvement of bony structure. So basically, it's a mass with a central necrosis and just abutting the veins, and with focal loss with involving the pericardium too. So now this is a 45-year-old female with anterior mediastinal mass with a superior vena cava obstruction. So the initial question is, what are the possible initial differentials? So my first question will be to the surgical oncologist surely, because the patient first goes to them. So sir, Dr. Prashant sir, so what do you think initially?
Yeah, so a mass in the anterior mediastinum in a 45-year-old, I would put something arising from the thymus as the first. As the CT mentions, you have more in favor of a thymic carcinoma, or even probably a high-grade thymoma. Not definitely not an A or a B1, or it's not an early. The other thing which I'm also very keen, which I would specifically look for, because you have actually mentioned patient as hoarseness of voice. So what about AP window? because with the similar CT findings, I don't expect a patient to have hoarseness of voice. So I would carefully look at the AP window, and then if the AP window nodes are involved and other mediastinal lymph nodes are involved, then my differential diagnosis would be of the small cell or neuroendocrine originating from the thymus. These are some things which I would want to look for, because clinically patient is having hoarseness, then I am concerned about the AP window nodes, because when it's not that it's not uncommon, but my differentials would change depending on that. But most likely it would be because germ cell tumors at this age, no. Lymphomas without any other B sign symptoms and other things, I would keep it low down the order. It's something arising from thymus, or it could be a small cell carcinoma.
Yeah, surely, sir. Agree with your sir. Anil sir, any changes from your part, or you are agreeing with the diagnosis or differentials which we are keeping?
No, I agree with Dr. Prashant that I would also keep small cell lung cancer in the differential only because that there is a focal loss of pericardium and hoarseness of voice. And so the majority of the small cell lung cancer also present with the mediastinal nodal mass, so which can obstruct or which can present very similarly to the thymic carcinoma or higher grade thymomas.
Sure. Dr. Somnath, any changes from your side?
Hi, Amit. No, actually, these things, the possibility is definitely first for the thymic origin, thymic thymoma, high grade, or thymic carcinoma. Then there is a possibility of small cell tumors, small cell lung cancer, and definitely lymphoma, primary mediastinal B cell lymphoma can also be an option in this DD. Although the this classical features is not there, but sometimes is the age group and the gender and this SVCO quietly match from the PMBCL. It is, but definitely it will be the least possibility, but this is the option.
Yeah, surely the more common things comes more commonly. Dr. George, your comments?
Sir,
I think so. Dr. George, you are not audible. Okay. So surely this patient has basically presented with a feature of SVCO, so something aggressive disease is there. So we are surely what is the most commonly see is the small cell. Is a small cell lung cancer or really a thymic carcinoma in this patient? So the DDs, as we have already know, the thymoma, and from the anterior mediastinum, since the CT is showing in this group of patients, so thymoma comes initially the first in the list, followed by carcinomas or teratomas rarely with in this group of patients. So just I think so, Dr. George, you are not audible. Your connection is poor. You may rejoin. I think so, it will be better. Okay, so the presentations have already been discussed, so I'm not going in that regarding whether it's how does the patient present with the local symptoms like SVCO in this case of patient, or with a paraneoplastic manifestation, which we are not seeing in this group of patient. But thymic carcinomas surely are more aggressive with less extrathoracic metastasis as compared to others, with only less than 7%, though the liver and the bone are the most common site which it presents with. And since this patient is paraneoplastic, as we have already been discussed, I'm not going details in this. But the points of myasthenia gravis has been greatly covered by Dr. Prashant. So I move from here. So now regarding how to proceed with this patient. So Dr. Prashant, coming back to you. So how will you do the initial investigation if this patient with SVCO and sometimes shortness of breath will come first time in the OPD?
Yeah, so this patient, we have only few differentials. The list what you pointed out, so mine is more in favor of a small cell or a thymoma with probably an aggressive variant. And sure. I'm not going to take the patient for upfront surgery without a biopsy. I'm not very comfortable with the clinical presentation. So I would go in for a biopsy. So from the mediastinal mass, and then depending on the biopsy, I would do a PET. If it comes as thymoma, high grade, or a thymic carcinoma, then probably role of PET is very limited because CT covers most of the things. If you just cover an abdomen and adrenals, most of the thing is taken care of. But yeah, if it comes as a small cell, then the management is going to be completely different. Even the workup, diagnostic with an MRI, everything adds on to it.
Yeah, great. So, in which cases are you going for upfront surgical resection, not going for a biopsy?
Yeah, so the upfront surgical resection is something which you have a very well encapsulated lesion. You know that the planes are very well maintained, and you can get the mass en bloc without causing a breach in the capsule. So these are patients where I wouldn't want to do a biopsy and cause a breach. So here you have a patient, though the planes with the brachiocephalic and SVC seems to be good, but patient is having clinically superior vena cava obstruction with hoarseness of voice and probably something in the, I'm not very comfortable going. I would want to get a biopsy and then take it forward.
Yeah, sure, sir. So basically this patient has also undergone an FNAC at that time, but which was clearly at the center is showing features of thymic neoplasm. So now coming to Dr. Tripti ma'am. So ma'am, are you comfortable with the FNAC doing in this kind of patients, or you need a biopsy to diagnose?
So sometimes in FNAC it becomes very difficult. Am I audible?
Yes,
Yeah.
ma'am, you are completely audible, please.
So it becomes very difficult, though there are some diagnostic features. I mean, if you see a large number of epithelioid cells, the problem comes when it is like a B1 kind of thymoma, like entirely immature T lymphoid, and you may misdiagnose this as T lymphoblastic. So that is one gray zone in which you are very skeptical, because that is mainly diagnosed on biopsy with the meshwork of the cytokeratin that you see, and you hardly see any epithelioid cells. So for me, biopsy is preferable and not FNAC.
Sure. So are you going to do ISC also on these kinds of patients of thymoma? And at least which ISCs are the initials at least needed?
Sorry, can you repeat?
Ma'am, role of ISC in diagnosis of thymoma. So are you doing ISC also?
Yes, yes. So basically any mediastinal mass, first you see whether it is lymphoid predominant or epithelioid predominant. So mostly type A, which is like epithelioid predominant spindle cell morphology, your IHC should be mainly cytokeratin, 1-TDT and Paxate. So Paxate comes in epithelial, which shows thymic origin. And then if it is type A, we also put like CD34, which will differentiate it from SFT. It has a very mesenchymal look. And moment the B1, B2 and everything starts, so it is more of lymphoid cells. So all there will be a sea of TDT positive immature, but the A1, A3 meshwork will help. So that is for B1 versus T lymphoblastic lymphoma. And when it comes to thymic carcinoma versus thymoma, there are some markers like CD5 and c-KIT, which will help in defining carcinoma. So there are some important roles of IHC.
Sure, ma'am. Great. Yeah. So basically we have initially to look for the morphology, and based on the morphology, the ISC has to be put in these group of patients. So radiological features has already been discussed, that the CT is the most initial investigation we are doing in these patients. And if there's a thymic carcinoma, these patients may have more necrotic or cystic or calcified areas as compared to the thymoma, which as already said is a homogeneous engulfed masses. But CT finding are also different. Somehow we can see in a different type A, B or C. It may be somehow in type A it's a rounded smooth, whereas in type B there may be more frequent calcification, whereas type C, as we know, is showing the invasion. MRI role has already been discussed. It's rarely needed, but surely to look for the neurovascular bundles. And sometimes when we have to look for the hyperplasia, and if we are finding it difficult to differentiate from any cystic lesions, in those cases, PET surely have got a limited role in thymoma, but surely in thymic carcinoma, it has got a role in this group of patients. So this, since we have discussed about the tissue diagnosis, is compulsory surgery. As already discussed by Dr. Prashant, that based on the CT finding, we can go for upfront surgery in this patient, but for thymic carcinoma, surely is planning to do this biopsy upfront. So as we already know that definitive diagnosis is going with a surgical resection or with a core needle biopsy. ISC markers, ma'am has already discussed different, and in the initial we have already discussed. So now regarding the staging, again coming back to Dr. Prashant sir. So which staging at present are you following? So there are now multiple stagings which are right from the Masaka-Koga to now the TNM. So for resectability, what are you considering now, sir?
PECT chest with abdomen is the gold standard, and that gives us most of the details. I would say 90% of the 99% of the times I'm happy with that. Very rarely that you would want an MRI of the chest, very rarely, but that situation may not arise, because if you're asking for an MRI, the disease is definitely locally advanced, and you are not going to plan for an upfront resection for sure. So the role of MRI in initial thing is, it's always debatable. I'm sure that PET would pick up so many things elsewhere, but in thymoma or thymic malignancy, there is no level 1 evidence to recommend PET routinely. The most common site of metastasis is pleural metastasis, which can be picked up by a good CT scan. And if you cover the liver and the abdomen, the adrenals, CT is actually good enough. A PET may not add over and above, and the evidence is limited. And mind you, in a patient with an anterior mediastinal mass, which you've already mentioned here, always evaluate for myasthenia gravis. Do not do the mistake, because 50% of them do have these symptoms, and ACH, at least an anticholinergic antibody, should be sent in these group of patients before you embark on any form of surgical treatment for these patients.
Yeah, sure, sir. Points well taken. So this is just a flowchart. Basically, regarding your comments about the tumor markers. So since he's a lady, we rarely see a mediastinal germ cell tumor. But if it has been a male, so you would be going for the tumor marker upfront for this group of patients?
The age is very important. So 45 years and the radiological findings. Radiological findings also help. The only radiological finding in this patient was, calcification. Something that that can happen over chronic this thing. So that's the only age. Yes, tumor markers would be required. I agree, 45 is something on the borderline. If this patient was a decade earlier, my first choice of investigation would be tumor markers, because you don't even need a biopsy at that time if you have positive tumor markers.
Sure. So yes, sir. Now coming back to stage, this question basically to and Dr. Anil sir. So what are you now following? It's a modified Masoka staging or the TNM staging? So we are comfortable with which one nowadays?
As far as the staging is concerned, I think the most commonly used is the modified Masoka-Koga staging system. However, it is preferable to add TNM staging also for the uniformity between the database, because thymomas are generally rare type of tumors, and we will not be able to get the data if we are not doing a uniform staging system. So as Dr. Rajiv has already mentioned in his talk, that we should both report the modified Masoka-Koga staging as well as the TNM staging. So because ISLC and ITMIG, both group have mentioned that the thymoma and thymic carcinoma should be staged according to the AJCC 8th edition. But yes, historically the modified Masoka-Koga staging has done pretty well as far as the prognostication of the surgical patients are concerned.
Yeah, completely. Getting back to Dr. Prashant sir. So if you're taking the patient for surgery, so are you going for everyone, or the resectability is being defined as we see in the TNM staging from stage 1 to 3 are considerable?
Yeah, T1, I mean, like, T3, it depends on the extent of involvement. I wouldn't consider all T3s as resectable tumors. So yes, technically, yes. So you can go ahead and resect superior vena cava, you can resect the chest wall, you can resect, the brachiocephalic lung can be taken. So that's not what is important. Here you're trying to make sure that the most important thing is not having any residual disease during your surgery. Okay, so that, Anil can help us by doing. But if I do an incomplete job, then even Anil is not going to say, oh no, boss, you have left a gross residual disease behind. Okay, so leaving behind gross residual disease, then asking Anil to help, I don't think is correct. So your primary aim should be to achieve an R0 resection as much as possible. So I wouldn't consider even T3 as an upfront resectable disease. I would biopsy these group of lesions.
So, sir, if you are getting a patient, if you are not getting R0, you're thinking if at least R1 you are getting. So are you planning to give something new adjuvant and then to take for surgery, or R1 you are going for upfront surgery?
Yeah, I would work out the feasibilities for some form of neoadjuvant treatment if I am not actually going to achieve an R0 resection. See, there's a subtle difference. It is R0 or R2. R1 is something which Dr. Trupti has to, R1 is something that, which Dr. Trupti has to tell me based on my intraoperative findings. So because the capsular breach and something like that, it's R2. If I can make out that I have left something behind, it is R2 resection. So just to be clear, so there is no R1 that I can make out. So it is either R0 or R2. So yeah, I would bang on. I would err on the side of giving some form of neoadjuvant.
Sure, sir. So yeah, coming back to Dr. Trupti ma'am again. So ma'am, this is what we have discussed about the histopathological features of differentiating between thymoma and thymic carcinoma. So the first thing what we have said is about this, you look for the spindle epithelial cell. So type A means, can you just elaborate how you'll differentiate between type A and type B in this group of patients?
Okay. So first of all, when you get a biopsy, just see whether you are seeing lymphoid cells more or epithelial cells more. That is the first thing. When you see mainly lymphoid cells, it is one of the categories of type B. So that is that. If you are seeing epithelial cells, then you categorize whether it is spindle or it is polygonal. If it is predominantly spindle without any admixed lymphoid cells, it is more of a type A. And then there are cases where you see admixture and you tell that whether it is type AB or not. When it comes to B, like type B1 will be entirely lymphoid cells. You have to hunt and then you actually think of lymphoblastic lymphoma and you get a measure. That is how a B1 will look like. In B2, there will be a lot of lymphoid cells, but then you will see clustering of epithelial cells and you will call it B2. Now, important thing is to differentiate B3 versus thymic carcinoma, which is very difficult when it comes to biopsies. In resection, yes, you see a lobulated pattern, but in biopsy, you just get a core and you can't. So that time you will correlate with imaging whether the neoplasm was lobulated. So B3 versus thymic carcinoma, both will show little epidermoid features, some atypical features. But when it comes to thymic carcinomas, I said there are some IHC markers which will help, positivity will help you tell whether it is thymic carcinoma or not. So that is the overall scenario. And then you put IHCs accordingly.
So for thymic carcinoma, it is CD5 and KIT, which you are saying is
yes.
To differentiate from
yes.
B3.
And sometimes you say obvious carcinoma with lot of keratinization and glandular features or whatever, then it is very easy to call that it is a carcinoma.
Yeah. Okay. Thank you, ma'am. So now again the question for Dr. Prashant. So the criteria for resectability you have, sir, already discussed. If there is an R2 resection, you are getting something you are not finding, you are completely going to resect those patients. You are going for the neoadjuvant therapy. So which structures, surrounding structures, you makes that tumor unresectable?
Yeah. So technically speaking, deep infiltration into the pericardium with infiltration into the chambers of the heart is something which makes it completely unresectable. So otherwise, phrenic can be taken care. Bilateral phrenic, dangerous, but then yes, I mean, it's very uncommon to have bilateral phrenic involvement. You can left brachiocephalic, superior vena cava, arch of aorta, all these things can be taken care safely. I mean, but it depends on the expertise of the center. You need to have a good cardiac vascular backup. You need to put these patients, but deep infiltration into the cardiac chambers or in the middle mediastinum with extensive nodal involvement, tracheobronchial tree, major tracheobronchial tree, extensive lung. There are a few case reports where they have some of the authors have done pleuropneumonectomies for extensive thymomas. That is, centrally located lesions. But those are just confined to case reports. So we do not know whether it would really add on to the survival or not. But yes, these are the points where we could consider for resectability versus unresectability.
So do you consider cytoreduction as a part of treatment in this group?
Yes,
patients?
Yeah. Gross, cytoreduction does help when you know that you have given some form of treatment and you have no other choice. Then cytoreduction also has shown survival advantage over not doing anything in this group of patients. But majority of them, it is actually quite challenging. We may think that, okay, try open up the thorax and take out as much as possible and come out. but it's quite challenging. Cytoreduction, whatever evidence is available, yes, it does. Personally, yes, I do not have experience much on that, but yes.
So what is the role of minimal invasive? Are you routinely doing minimal invasive surgery in this group of patients?
Yes, for localized lesions. So I confine myself for a VATS. I generally confine to 5 to 6 centimeters is what is my cutoff is, and what literature says is also about 5 centimeters. But for robotic, after the robotic, because the chances of the handling the thymus, okay, we are all worried about rupturing or causing injury and spillage. So there is safety data till about 8 centimeters, but there are a few case series even beyond 8 centimeters, but I'm not very sure whether you should be doing for larger lesions, because you don't want to, cause a capsular breach and make it more worse. Minimal invasive is a safer approach for highly select patients. For non-thymoma, if you're doing in myasthenia gravis with non-thymoma, definitely minimal invasive surgery adds on, a quicker recovery in these group of patients rather than a sternotomy. But mind you, don't compromise on the extent of resection. It has to be a radical thymectomy.
Okay, so points well taken, sir. So now coming to Dr. Anil, sir. So RT is the main adjuvant now in this group of patients with thymoma and thymic carcinoma. So what are the, you have discussed already in your slides. So just to brief once again, what are the doses which we are using in the radiation for thymoma patients and in thymic carcinoma, if there is an R0 resection and when there is an R1 resection?
See, the most important point here I would like to highlight is that the post-operative radiation therapy in thymoma is not based on randomized controlled trial. It is based upon the retrospective data and the guidelines that the expert has given. So it's not always that you should consider stage 2 to stage 4 thymoma always. So depending on the pathological classification, the inputs from your thoracic surgeon, whether they are how well they have done the surgery, whether there is any doubt about the margins or about the residual disease, what is the pathological classification A, AB, B1, B2. For example, if it is a stage 2 but type A tumor, I would not offer the patient adjuvant radiation therapy. So the chances of recurrence in stage 2 type A will be less than 10%. And if the recurrence happen, then the surgery, if it is possible, will give you a longer overall survival. Only in stage 2B, B2, B3, I would be very comfortable in offering the radiation therapy to decrease the chances of the relapse. However, the database has shown that there is an overall survival improvement. We should not or we should not take that with a very hard level of evidence, because these are just the databases. We don't know how the databases are entered. Even if it is a US or National Cancer Database, we need to carefully look at the data. As far as the doses of the radiation therapy is concerned, if it's an R0 resection, then 45 to 50 gray is more than sufficient. There is no need for any dose escalation over there. 45 to 50 gray will take care of your microscopic disease. But if it's an R2 resection, or if it is an unresectable thymoma or thymic carcinoma, then yes, to the gross disease, a dose of 60 to 66 gray in 30 to 33 fraction once daily regimen is required. As far as the delivery technique of radiation therapy are concerned, mind you, so these are the treatment which we are going to offer because we want to reduce the local recurrence rate. Okay, so we should not give radiation therapy when there is a very large post-operative tumor bed, and we should always discuss with the thoracic surgeon, like Prashant has already mentioned, that it should be a multidisciplinary tumor board approach between the thoracic, the surgical, between the surgical, medical, radiation, and the pathologist as well as the radiologist. And in unresectable cases, doses should be 60 to 66 gray, and we should always take the help of thoracic surgeon as well as the pathologist while we are defining our target volume. It is very important.
Yeah, sure. Thank you, sir.
Dr. Amit, if I may ask a question to Dr. Anil. Anil, what's your take on pre-operative, like, in totally unresectable neoadjuvant sort of a radiotherapy? I know I'm not very sure whether I can call it neoadjuvant, but pre-op RT, and what's your experience with the same?
So, Prashant, frankly speaking, we haven't offered any patient the approach of neoadjuvant chemo radiation or neoadjuvant radiation therapy. So because whenever the patient is unresectable, so mainly because of the tumor size and the infiltration into the adjacent structure, and then the possibility of as the thymomas are not very high grade type of a tumor, means the proliferation rate, so they will not respond very quickly, so that the patient can be resectable in a 2 months time. It will take time to respond to radiation therapy. So I personally haven't offered any patient neoadjuvant chemo radiation therapy to make them resectable. However, the main treatment regimen is the neoadjuvant chemotherapy. If it is become borderline resectable to resectable, then yes, the surgery can be offered. Neoadjuvant chemo radiation therapy is largely experimental, I would say.
Sure, sir. So the next question was similar about these unresectable tumors, whether to go for a definitive chemo radiation or versus an R2 resection followed by the adjuvant therapy. So
I think largely this decision depends upon the surgeon. So because if they are comfortable in preoperatively, if they think that they could reset the tumor with an R0 recession, however, when you when you open the patient, as Dr. Prashant has already mentioned, if they found that the tumor is not completely resectable, then yes, they should do a maximum safe recession, and they should put the surgical clips. So I would say that upfront surgery or neoadjuvant chemotherapy followed by surgery, and then the post-operative radiation therapy will be a better approach. So because this has the largest data as of now. But if the patient is completely unresectable, as Dr. Prashant has already mentioned, then yes, so definitive chemo radiation will be a better option.
Yeah. Okay. Thank you, sir. So now coming to the role of concurrent chemo, sir, you have already discussed. To coming to the medical oncologist. So Dr. Somnath, if we are planning for a concurrent chemotherapy in this group of patients, so which chemotherapy regime are you going to take?
Yeah, definitely. If a concurrent chemo radiation is planned, although we have not so much robust evidence of which is better, because there's scarcity of a large-scale prospective randomized trial. So as of now, we extrapolate the data from role of chemotherapy. Cisplatin will be my choice with a weekly or 3-weekly based regimen according to the creatinine clearance, GFR, and patient performance status. So platinum will be the ideal in this situation when concurrent is used. And apart from these, we can use the cisplatin etoposide base also in some cases.
Yeah, surely, completely agreeing. Cisplatin etoposide, though the studies are there with the cisplatin and etoposide, though we may rarely go with the cisplatin alone in this group of patients. So coming to Dr. George, so palliative chemotherapy options. Do you think that they have got any advantage if the patient is completely unresectable and you are not getting any not able to go for surgery or chemoradiations? So palliative chemotherapy has to be given. And what are the chemotherapy regime are you planning in this group of patients?
I would like to first assess the fitness of the patient, and if the patient is cisplatin eligible, then I would like to consider chemotherapy regimen with cisplatin combination with cyclophosphamide and doxorubicin cap regimen. There are also other regimens with cyclophosphamide, doxorubicin, vincristine, and cisplatin regimens. But this can be given only for fit patients, with patients who can be cleared for cisplatin. If the patient is base regimens, then paclitaxel, carboplatin.
Okay, fine. I think so. We have lost Dr. George. Coming to back to Dr. Somnath, are you planning to do NGS in this group of patients?
Frankly speaking, as of now, we are not doing routine NGS in this case because we don't know what are the targets and the role of targeted therapy with the base of NGS still in an experimental study. So outside clinical trials, it is difficult to do a routine basis in NGS. And these things, some data will be there, are there regarding this target of EGFR, c-KIT, and these things. But still, it is all are experimental, I think. So we are not. I don't recommend routine NGS in this case unless until it is a metastatic and failure to the first line therapy. Patient is very keen to take some therapy which are sometimes facing in our clinics. In that case, we can look at the NGS.
Yeah, okay. At this point, I want to take the opinion of Dr. Tripti also. She is a routine part of a molecular tumor board. So, ma'am, are you if the patient has relapsed after the first therapy she has received, so NGS is an option for this group of patients?
Actually, if you see thymic carcinomas or anything, most of them have the copy number variations, like most of it, and there are some mutations, and mostly you get P53 mutation, especially in carcinoma. So not much targetable mutations that you see. So as of now, I'm not that convinced for the role of NGS as such in, and whatever cases also, few cases that we have got, we have the similar profile. Not much target that we have found.
Yeah, surely there are only few targets, and the most common drugs which we are using here might be sunitinib and lenvatinib in this group of patients. Apart
Amit,
from
Amit, sorry to interrupt. Can we conclude in the next few minutes?
So, the last thing is about immunotherapy in the later lines. They has got some role, but surely not in thymoma, as there are, everybody knows there is a large number of immune-related adverse events in these group of patients. Otherwise, in thymic carcinoma, surely if the PD-L1 expression tumors are there, there is some role of immunotherapy in second line or third line in this group of patients. So I thanks all the panelists for their great discussion, and I think the whole thymoma part and thymic carcinoma has been covered today, and all the doubts have been cleared of all the persons who are listening to this panel discussion and also the initial talks by the all. So thank you, everyone.
Thank you. Dr. Amit, sorry, one last question I wanted to ask. Like imaging findings was like necrosis, like central large areas of necrosis, and biopsy you got just suggestive thymoma. So are you thinking that you have some missed any high grade areas in biopsy? And in such cases, are you looking for any subtype of thymomas? What do you expect from a biopsy?
So surely in this group of patients, the finding is more in favor of thymic carcinoma because of the large number of necrosis and the picture, the patient aggressiveness disease they have presented. So we'll surely, though the FNA has been done in this patient, we'll surely plan for the biopsy in this group, this patient. And we have to rule out between thymic carcinoma or an aggressive B3 type of thymoma in this patient. Okay. Thank you, ma'am.
Thank you.
Thank you, Amit. That was a great panel discussion, and thank you to all our panelists for the great discussion. With this, we move on to the next session. So I would like to invite the coordinator for the next session, Dr. Alok Goyal, Associate Professor of Medical Oncology from Homi Bhabha Cancer Center, Sangrur. Over to you, Alok.
Thank you, Dr. Nandini. So I'm on the organizing team. I would like to welcome all the delegates to a very interesting session on mesothelioma. We have a team of very expert speakers from all over the country lined up. So please stay tuned with us. For the first session, I would like to invite Dr. Parag Sanghvi, who is a consultant radiologist from Mumbai. He has advanced training and fellowship in chest radiology. So I will just ask all the speakers to please stick to their timing. Dr. Parag, please.
Okay, thank you. Thank you for the kind introduction, and thank you for inviting me for this talk. So over a period of just 10 minutes, I'm going to discuss about the mesothelioma. I'm a radiologist from Jankara Imaging. So I'll be talking about the diagnosis and response assessment imaging point of view. So as we know, the pleural mass is comprising of a vast variety of entities, but vast majority are there, but still most common are just in terms of malignant lesions, the commonest one being the metastasis and the mesothelioma. And right now we're going to discuss about the mesothelioma, and let's try and understand how to make this diagnosis, how to avoid the misdiagnosis, and how to differentiate from metastasis and other lesions. And then we'll briefly see about the response assessment as well. So mesothelioma, as we know, is the disease of elderly, and asbestos has been proven to have a direct link with asbestos exposure with the mesothelioma. So that history really becomes really important. And we also tend to see the other asbestos related diseases in the chest when we do a CT scan. So that we are also going to see. But typically we need a pleural biopsy for confirmation of diagnosis, and especially to rule out metastasis, which is far more common. And at times, even histopathology might be difficult, but with the advent of different immunohistochemistry and electron microscopy with different markers, now it has become really still feasible to differentiate the two. And in general, overall, the mesothelioma has a poor prognosis because by the time the diagnosis is made, it is relatively in the advanced stage. So imaging again becomes important, especially to differentiate from the benign pleural plaques and diseases that might be present, especially in our country in presence of tuberculosis. So typically the mesothelioma involves the parietal pleura, and fissural involvement is very common, which also really helps, and that I'm going to discuss in the coming slides. And typically it presents with the pleural thickening along with the mass-like thickening along with the pleural effusion. And there is something called as a frozen mediastinum sign that has been described, and I'll show with examples also. And typically the diagnostic tool used at the first time is CT scan. Typically a CT scan has been done, and sometime MRI may be done, typically used as a problem solving tool for particular answer that you need to get, especially whether the patient is operable or not, some specific answer. And that also we are going to see with examples. Perfusion MRI really helps in times of response to chemotherapy, and PET CT of course has a wide variety of uses once the diagnosis is established. So first, when you see a imaging or a CT scan, when should you think of a malignant mesothelioma, or when should your antenna go up when you see a pleural thickening? So typically the pleural thickening that shows some different imaging features that may suggest malignancy that we are going to discuss now. So typically the malignant pleural thickening will be nodular. So of course the benign may also show nodularity, but typically a more than a centimeter size of pleural thickening with nodularity is when you should be suspicious of a malignant disease like mesothelioma. And typically if you see the benign pleural thickening typically involves the costal pleura, and then asbestosis-related plaques even involves the diaphragmatic pleura. But typical involvement of a circumferential pleural thickening with thick nodular enhancement more than a centimeter in size, and typical involvement of the mediastinal pleura also should really alert us to think of a mesothelioma rather than a benign pleural thickening. So let's see this with example. So if you see, this is a enhancing pleural thickening on the left. You see some fluid also effusion, but see this is just about maybe a centimeter size, but there is no nodularity. And plus you can appreciate the changes of chronicity. That's a contracture of the hemithorax, volume loss that suggests that it has been around for a long time. And you might even see calcification along with also the volume loss signs and other sign of fibrothorax that is present in this case as well. So these are the typical presentation of a benign pleural thickening. As against this, the malignant pleural thickening will look something like this. So this if you can appreciate that this is much more nodular and showing a heterogeneous enhancement, clearly more than a centimeter in size, and also appreciate how it is circumferential rather than this costal and diaphragmatic involvement, and also the mediastinal pleura is typically involved. So this is how the malignant pleural thickening can be distinguished from a benign pleural thickening. And this is what I meant by frozen mediastinum spine, specifically useful with radiographs also. So it typically means is that though you have a mass pleural thickening and you have a pleural effusion, in mesothelioma, you don't see the typical mediastinal shift or the mass effect. The reason being there is a pleural thickening, but there is a restricted underlying lung expansion, and there may be possible mediastinal infiltration also not allowing it to shift to the opposite side. So there's, if you can see in all these examples, these are all three cases of mesothelioma. You can appreciate that there appears to be a pleural effusion or pleural thickening, but there is no mediastinal shift in any of the cases. So that is where the time, again, on radiographs particularly, you can think of a malignant mesothelioma. So let's see some cases. So this was a typical case of a mesothelioma. You can appreciate, again, there is a diffuse nodular enhancing pleural thickening that is circumferential involving the mediastinal pleura as well. There may or may not be the mediastinal invasion, and all those signs also we are going to see, and specifically how the MRI is going to be helpful in that. You have some pleural effusion also, and again, this coronal and sagittal reconstructions really help to pick this fissural involvement, which is also very, very common in mesothelioma, and that's how we make the diagnosis. One more example, you can see that there is a similar nodular enhancing pleural thickening on the right side. It is more than a centimeter in size. Mediastinal pleura involvement is also present, and we did the biopsy and the diagnosis was proven. So that's how the typical case of mesothelioma looks like on a CT scan. But then coming to the important question that when should you think of pleural mesothelioma and metastasis? So by and large, the biopsy will be required, and that's how the diagnosis is made. But in general, the important features that really helps is the mesothelioma will be typically unilateral, while metastasis may or may not be bilateral. So the rule other way around doesn't work, but if you have a bilateral disease, you are going to think of metastasis first. then you have a fissural involvement that is very, very common in mesothelioma as compared to the metastasis. And you as we discuss about the frozen mediastinal sign, you can see contracture of the hemithorax rather than the contralateral shift that is seen with metastasis. And then because typically most of the patient with mesothelioma have some other asbestos plaque related disease, so you will see those calcified pleural plaques and other sign. And in lung metastasis may be present. And of course, when you have a known primary that is present elsewhere in the body, the first thing then you will be thinking of a pleural thickening as a metastasis disease. So that was about the typical presentation on CT scan. But what is the role of a PET CT scan? So it can really help sometimes to differentiate the benign from the malignant pleural thickening. So at times, even the CT scan appearance is not very typical. The pleural thickening can be benign or malignant. And in those cases, the PET CT can really be helpful by picking up the FDG uptake and showing the activity. And more so important in nodal metastasis. So on CT scan, we rely on the size criteria. So the sub-centimeter size lymph nodes are difficult to comment on CT scan unless they show some other morphological feature like necrosis, etc. It is difficult to comment on disease spread in case of CT scan. While in PET CT, you can pick up the activity even in the sub-centimeter size lymph nodes. So the mapping of the disease curve will become really easy once the diagnosis is established, because it's a whole body scan. It's sometimes even the guidance for biopsy can be important with PET CT, that it allows us to pick up those active areas that you can use to target the biopsy, especially in a heterogeneous or a necrotic disease, to avoid any false negative biopsies. And of course, in response assessment. So this is how the typical PET CT looks like. Again, the similar findings of diffuse pleural thickening, nodular enhancing, and you can see how the FDG uptake is very easily appreciable in case of PET CT scan. And even this fissural nodules or the fissural involvement, and you can see even those also show FDG uptake. So that's how the PET CT can really be useful in diagnosis, guidance to biopsy, and even in response assessment. And finally, the role of MRI. So role of MRI is actually limited, and by and large, we will not be doing MRI unless it can be only used as a problem solving tool. So sometimes the chest wall or a mediastinal endothoracic fascia involvement that might upstage the disease or decide the surgical management. If the question is really important and it is difficult to answer on CT scan, then MRI can be really, really useful. Especially the diffusion imaging is also now coming big time for the response assessment as well, which is otherwise also typically done with dynamic perfusion studies. And even the dynamic perfusion helps for the pre-treatment to decide which tumor are more likely to respond to chemotherapy, because the high pre-treatment median efflux rate are more likely to respond to the chemotherapy. So an MRI, otherwise disease typical looks like this. The T1 signal is almost iso-intense or a mildly hyperintense as compared to muscle. T2 is heterogeneous signal intensity, but you will see some hyperintense areas and will show a avid post-contrast enhancement. But this is how it shows the chest wall and the mediastinal invasion so well. So while this can be sometimes difficult to pick up on CT scan or even with PET CT scan, MRI will show this beautifully, especially the post-contrast imaging, the chest wall involvement as well as the mediastinal invasion. And also you can see in this example, there is a fissural involvement, but the diaphragmatic involvement was really difficult to comment on CT scan, while on MRI, it becomes really easy to say that this was involving the diaphragm as well. So that's the importance of MRI, typically used as a problem-solving tool. And then this was all about the diagnosis and how to stage the disease, and about the response to treatment. So of course, whenever there is a chemotherapy is given and to assessment of response is decided, PET CT typically was the imaging modality of choice. But if you have doing just a CT scan, of course, you are relying more on the morphological response. So you can clearly see here clearly the disease burden has regressed, the size has come down significantly. So that's how the CT response is assessed. On PET CT, in addition to the size or the morphological response, you can comment on the metabolic response as well. So whether the residual thickening is still metabolically active or not, only a PET CT can tell. So as you can see, there is a good partial response, but still there is FDG uptake suggested there is a residual disease present in this case. And even so, more important to pick up small recurrences. So this patient, if you can see, there is a pneumonectomy done. And in post-op imaging on CT scan, there were lots of soft tissue thickening, but it was difficult to comment and differentiate from the post-operative changes. So again, the PET CT will really easily show this FDG uptake wherever there is areas of recurrence. And that's how it can be really useful in case of post-operative status also. And finally, for MRI, again, in response, just like in diagnosis or staging, it comes as a problem-solving tool. Similarly, in response assessment also, especially because of the diffusion-weighted imaging and the perfusion imaging, it can really become easy to pick at times. And there are lots and lots of new articles that are coming that are exploring the use of diffusion-weighted imaging though we have also not yet explored it completely, but this how it has been a promising tool that the article describes that the post-treatment, if the rise in ADC value is easily much more appreciated, then it suggests the response to treatment. And same way, the perfusion imaging can also be really helpful. So the images on your left are pre-treatment, while imaging on the right are post-treatment. And you can see, apart from the morphological response, there is a significant drop in the KEP value or the perfusion of the tumor also that's suggestive of a response to treatment. One more example where you can see on pre-treatment, there was a diffuse disease, and with post-treatment, the disease has gone significantly down. And more so importantly, the perfusion values have also gone down significantly. So to summarize over, I think just about in 10 minutes, what we have tried to understand is the various importance of the radiological modalities like CT scan, PET-CT, and MRI for the diagnosis of mesothelioma. And we understood how we'll differentiate the benign from the malignant disease. When should your antenna go up and you should be suspecting a malignant disease? There are certain signs that may suggest metastasis versus mesothelioma, but typically we will end up doing a biopsy to confirm the diagnosis. MRI can be really important problem-solving tool, both in the diagnosis, especially for staging, mediastinal invasion, diaphragmatic invasion, etc., and even to response to treatment with perfusion and diffusion-weighted imaging. And PET-CT is, of course, really helpful for the mapping the disease in the body, guidance for the biopsy, as well as the response to treatment. So with that, I will conclude my talk. Thank you so much for your attention.
Thank you, Dr. Parang. That's excellent and exhaustive review on radiological nuances in mesothelioma. I will now invite my next speaker, Dr. Devyani Niyogi, who is an assistant professor in the Department of Surgical Oncology in the Unit of Thoracic Oncology. So over to Dr. Devyani. She will be talking on surgical management in mesothelioma.
Hi, Alok. Thank you very much. And I'm glad to be here. And Parang, that was a lovely talk. I thoroughly enjoyed it.
Thank you.
I'm just going to share my screen here. Yeah, are my slides visible?
They're visible.
Yeah, perfect. So my talk right now is going to be about the role of surgery in pleural mesothelioma. And as we've already covered, and Parang's described it beautifully, that the histopathological diagnosis would either be with a pleural biopsy, a fluid cell block, or in some cases, it mandates a thoracoscopic biopsy. And you need 2 mesothelioma markers to be positive and 2 adenocarcinoma markers to be negative to conclusively call it a mesothelioma. It's staged with a PET-CT, and most centers treating mesotheliomas prefer an invasive mediastinal staging to rule out contralateral mediastinal adenopathy, because that confers extremely poor prognosis in this disease. So the first question that we'll try to answer before we go into the details is, does surgery really help in this kind of a disease? And to answer that question, we have this graph from the SEER database analysis, which shows that all treatment combinations that involved surgery as a part of the treatment did better in terms of survival. So simply put, yes, surgery does help, which brings us to the next question, that when will you think of offering surgery to a patient with mesothelioma? The most important factor to consider here is the patient's performance status, because as we discussed, mesothelioma is going to have a combination of treatments, and you need your patient to be extremely fit to be able to undergo all these demanding treatment. Needless to say, non-metastatic disease and epithelioid histology with no contralateral mediastinal nodes, which in the case of mesothelioma are labeled as N2, are typically the best patients that you would choose for curative intent surgery. A lot of these patients, even with localized disease, come with effusions. What's important to understand is, if we have already established the tissue diagnosis, an asymptomatic effusion is best left alone. Do not intervene if the effusion is not symptomatic. But sometimes, like this scan shows, there are large symptomatic effusions which mandate drainage. And as far as possible, a thoracocentesis should be done to get the fluid out. If the effusion is too large and you cannot avoid a drain, what needs to be kept in mind that the drain site needs excision during surgery, because they're potential sites for tumor seeding. And the drainage of the fluid improves the performance status of the patient and may improve their chemo tolerance. Generally, any mesothelioma is operated after 3 or 4 cycles of neoadjuvant chemotherapy, which is generally pemetrexed and cisplatin based. But if it is an extremely early stage mesothelioma, there are reports of upfront surgery, and that is a reasonably acceptable strategy too, as long as R0 resection or a maximal resection can be achieved. The response assessment, like Parag said, is with a CT or a PET CT. And unresectable disease in cases of mesothelioma are disease that extend transdiaphragmatic into the abdominal cavity, the contralateral chest, or extensive chest wall involvement, which makes resection impossible. Any surgery for mesothelioma, whatever we pick, is extremely demanding, both for the surgeon, more so for the patient. They alter the physiology of the patient quite significantly. So a good functional evaluation cannot be more stressed upon. Pulmonary function test, DLCO, a perfusion scan to look as to how much the lung underlying the pleura is actually contributing to the patient's lung function are of paramount importance. So is a cardiac evaluation. Optimizing comorbidities is important before surgery. Prehabilitation becomes extremely important at least 2 to 3 weeks prior to surgery in the form of physiotherapy and high-intensity interval training. The types of surgery for mesothelioma were very elegantly classified by the ISLC. Partial pleurectomy and a simple pleurectomy decortication are procedures which are reserved in the metastatic or palliative setting. What we are more interested in is the curative intent surgery, which is either an extended pleurectomy decortication or an extrapleural pneumonectomy. An extended pleurectomy decortication, or an EPD, basically involves removal of both the pleural peels, that is the parietal as well as the visceral pleura, while maintaining the lung intact within the pleural cavity, whereas an extrapleural pneumonectomy does all this along with the removal of the lung. The diaphragm and the pericardium may be excised as involved. The lymphadenectomy involves a standard mediastinal lymphadenectomy that we do for non-small cell lung cancer. In addition to that, special attention should be paid to the internal mammary chain of nodes and the cardiophrenic and the costophrenic recessed nodes, because that's where pleural disease primarily goes to. This brings us to the very popular, famous MARS trial, which was headed by Tom Treasure, which looked at the role of an extrapleural pneumonectomy in the treatment of mesothelioma. It was a randomized controlled trial with 12 centers in the United Kingdom. To show a difference, the estimated sample size was actually 670, but this trial accrued only 50 over a period of 3 years. It required the mesothelioma to be pathologically confirmed, the patient fit for trimodality therapy, staged with a PET and a mediastinoscopy, receiving 3 cycles of platinum-based chemotherapy as neoadjuvant. This chemotherapy was not standardized, and the patient was then randomized into either an extrapleural pneumonectomy followed by hemithoracic radiation versus no EPP and continuation of chemo. When they realized that their accrual is going slow, they changed their primary endpoint to make it a feasibility study of randomizing 50 in 1 year. They took 3 years, so the primary endpoint was not met. The secondary endpoint was completion of therapy, morbidity, mortality, quality of life, and survival outcomes. Of the 24 patients randomized to the EPP arm, surgery was attempted only in 19. The remaining either progressed on chemo or refused consent, and the surgery was actually completed only in 16 patients. In these 16, the mortality was 16% and the morbidity 70%, which is staggering. And it's actually higher than most series of mesothelioma. 50% completed therapy. Most of these patients were actually ideal mesothelioma candidates. Good performance status, epithelioid histology, node negative. At 2 years, the median OS was 14 months in the surgical group, whereas it was 19 months in the non-surgical group, which was a little bit surprising. Quality of life wise too, patients who underwent an EPP actually did worse. So the authors concluded quite boldly that though the data is limited, EPP has no role within the trimodality therapy and possibly harms the patients. But this conclusion came a little bit fast and was faced with a lot of criticism, most famous being these 2 papers. Obviously, they pulled out the trial because of its poor accrual, the non-standardization of chemotherapy, and the extensive crossover between the 2 arms. So what this trial did establish is that EPP is morbid. There is a lot of mortality associated with it. But if you look at other series which reported on its EPP outcomes like Sugar Bakers or Raja Flores' series, the morbidity and mortality was quite all right, 19%, 6%. And they showed a median survival of almost 51 months in favorable patients, that is good general condition, epithelioid, node negative, R0 resection, which are generally the kind of patients that you would apply a trimodality treatment for. More than that, the ISLC data also said that EPP is probably better for early stage disease in terms of overall survival and recurrence. And the NCDV analysis also showed that surgery is very much important part of the treatment algorithm. EPP is a procedure fraught with risk. Pneumonectomy itself is a disease, a lot of hemodynamic instability, arrhythmias, SIRS, and a surgeon's nightmare, a bronchial stump blowout. This brings us to the more friendly extended pleurectomy decortication. The most important part here being that the lung is saved, which itself brings down the morbidity and mortality to almost 1/3 of that seen with EPP. But you need a disease that fits the bill. So this kind of disease, which is mainly effusion-based, response is amazing to chemotherapy. This looks like a normal scan. This is an ideal candidate for an extended pleurectomy decortication. This is not without its complications. Because you strip the visceral pleura of the lung, they are prone to have prolonged air leaks, intercostal drainage, which leads to empyema. Arrhythmias and SIRS are a part of this procedure as well. To put this procedure in a randomized setting, we have the MARS-2 trial, which was designed by Eric Lim and is currently accruing, which looks at 2 cycles of chemotherapy randomized to EPD versus no surgery, followed by 4 cycles of chemotherapy. It's accruing much better than the MARS trial, and the results are eagerly awaited. So all surgeons who operate on mesothelioma say that wherever possible, a pleurectomy decortication should be the way to go. But then again, once in a while, you come across such disease where despite chemotherapy, the disease is infiltrating into the lung parenchyma, and you're left with no other choice but an extrapleural pneumonectomy to get a maximum complete resection. So the International Mesothelioma Guidelines gave that all patients should be discussed in a multidisciplinary clinic. Histology and the nodal status should be identified prior to therapy. A macroscopic complete resection is the aim. The type of surgery actually depends on the type of disease and the expertise of the patient. Surgery again comes in effusion management in the palliative setting, where the fluid can be tapped, drains can be inserted, indwelling pleural catheters can be kept. Talc-pleurodesis may be performed, but is not very effective because of all the pleural disease, and pleurectomy decortication only in very select cases. 2 randomized trials in this setting, the Mesovats compared pleurectomy versus talc-pleurodesis, found no difference in survival. The MesoTrap is still accruing, which is looking at partial pleurectomy versus indwelling catheters. I'd like to conclude by saying that mesothelioma is a disease that needs a very nuanced management with a multidisciplinary team. Surgery still offers the best survival, and we need to identify the potential surgical candidates extremely early in their disease. The best outcomes are seen with fit patients with epithelioid histology and node negative disease. The choice of surgery, EPP versus EPD, depends on the patient profile, the kind of disease that the patient has, and this operating surgeon as well. Thank you very much. I'd love to take any questions.
Thank you, Dr. Devyani. I don't see any question in chat. We will take any question in the panel. For the next step, I will like to invite Dr. Sunil Chobade, who is a consultant medical oncologist at Tata Memorial Hospital, Mumbai. He will be talking on the role of systemic therapy and any new advances in the management of mesothelioma. Over to you, Sunil.
Good evening, everyone. First of all, thank you for this opportunity. So I will be discussing about systemic therapy, chemotherapy, immunotherapy, and recent advances in the management of mesothelioma. Sorry, my apologies. There was some technical error. So we have discussed a lot about the characteristic of mesothelioma and the diagnostic diagnostic as well as role of surgery in mesothelioma. So usually mesothelioma is a disease of elderly with a presentation at latter stage of the life. So it's an aggressive malignancy with overall poor survival outcomes. The 5-year survival outcomes range in the it ranges in the 10%. If we see a stage-wise outcome, the stage 4 disease has a median OS of 14.9 months. We have discussed the etiology and diagnostic things. So asbestos is the main etiological factor. Clinical presentation, as we all know, chest pain and dyspnea are most common symptoms. Patient may present with pleural effusion and rarely localized mass. So it is challenging to differentiate between the metastatic pleural disease and the malignant pleural mesothelioma. So we have discussed this part. We have discussed the role of imaging, histopathological classification. We have discussed the ISC thing. So at least 2 positive mesothelioma markers and 2 negative adenocarcinoma markers are required for diagnostic accuracy. There are some genomic studies going on. Loss of BAP1, loss of CDKN2A, and loss of MTAP have been associated with mesothelioma, but they have no currently they have no role in diagnostic. So in management algorithm, we have seen if patient is suitable for multimodality treatment, we consider for macroscopic complete resection and chemotherapy. So we will move to systemic therapy in advanced disease. I will be covering treatment in first line, maintenance therapy, recent advances, and the further lines of therapy. Despite the various efforts, we have been not able to achieve promising results in mesothelioma. In resectable disease, we have some trials where induction chemotherapy has played a role and it's a standard of care. So we have this trial by Krug of pemetrexed cisplatin, where the response rate was 32.5% and the median OS was 60.8 months. So this is a guideline for systemic management. So if patient is suitable, is unsuitable for multimodality treatment and is being planned with palliative intent treatment, we have a immunotherapy in first line, which includes nivolumab plus ipilimumab. If PS is bad, we can choose best supportive care. If patient is not feasible for immunotherapy, we have systemic therapy in the form of pemetrexed and cisplatinum or pemetrexed and carboplatinum for cisplatin unfit patients, followed by plus minus maintenance gemcitabine. Also, we can use bevacizumab along with pemetrexed and cisplatin. At disease progression, we use single agent chemotherapies that include vinorelbine, gemcitabine, or we use single agent immunotherapy, and there is a new data coming on gemcitabine and ramucirumab. I will be discussing in further slides. So this is the this was the first trial for pemetrexed and cisplatin in unresectable mesothelioma, where patients were randomized to receive pemetrexed and cisplatin against cisplatin. The primary endpoint was OS. Secondary endpoints was response rate, quality of life, and toxicity. So we achieved a median OS of 12.1 months in the pemetrexed cisplatin arm versus 9.3 months in the cisplatin arm with a hazard ratio of 0.77. So this trial, neutropenia was the most common toxicity, followed by nausea, vomiting, and fatigue. Other platinum that were tried, pemetrexed and carboplatin, the overall response rate was 18.6 months and 12.7 months. It was comparable. We use carboplatin in the setting where patients are ineligible for cisplatin therapy. This trial was rallitrexate and cisplatin. Here, the overall response rate was 24% and 1 year OS rate was 46.2%. So this is a study of frontline PEMCIS and bevacizumab in unresectable mesothelioma. Here they use pemetrexed cisplatinum along with bevacizumab, and in other arm they use pemetrexed and cisplatinum. 6 cycles were given and bevacizumab was used as a maintenance therapy. No crossover was allowed. So there was no OS benefit associated with the bevacizumab maintenance. On subgroup analysis, sarcomatoid histology favored responses to bevacizumab compared to epithelioid histology. Other maintenance therapies, those were tried, are pemetrexed and gemcitabine. Both drugs were evaluated in trials. There were modest responses were maintained, but there was no OS benefit in the final analysis. We come to the role of immunotherapy. So Checkmate 743 trial, this trial, it's an open label phase 3 study of nivolumab plus ipilimumab in mesothelioma, where unresectable mesotheliomas were randomized to receive nivolumab ipilimumab for up to 2 years versus standard of care, that is pemetrexed and cisplatin. Primary endpoint was OS and secondary endpoints were overall response rate, disease control rate, and PFS. So baseline characteristics were comparable in both the arm. The Nivo arm had 76% patients of epithelioid histology and 24 patients of non-epithelioid histology, whereas 80% were PDL1 positive and 20 were PDL1 negative. So primary endpoint, we have got the 3-year OS update for this study. So at median OS was 18.1 months versus 14.1 months with a hazard ratio of 0.74. When we analyzed this data at the end of 3 years, the OS was 23.2% in patients who received immunotherapy versus 15.4% in patients who received chemotherapy. On subgroup analysis, female patients having non-epithelioid histology and PDL1 positivity had better response compared to.
Hi, Dr. Sunil. Dr. Arif, could I request you to wrap up in next 1 minute? We are running a little late.
Yeah.
Thank you.
So this is a second study of confirmed study which evaluated nivolumab as a single agent in the first line, where it was compared with the chemotherapy, and we have a positive results with PFS of 3 months versus 1.8 months and overall survival of 9.2 and 6. Versus 6.6 months. So it's a promising study. In second line, we have option either we re-challenge with pemetrexed and platinum if the recurrences are more than 6 months. Other agents which can be used are single agent gemcitabine, venurelbine on pemetrexed. These have shown modest responses, but there was no OS and PFS benefit. Pembrolizumab was tried in phase 2 Keynote 150 study in second line, where 118 patients were enrolled. 8% patients has a objective response. Median OS was 10 months. This study showed a promising activity of pembrolizumab. This one trial is Promise Mizo, where pembrolizumab was used against standard of care in second line, and there was no OS benefit. So tremelimumab and tremelimumab was tried. It has a no rule. It has found no OS benefit. Thank you.
Thank you, Dr. Sunil, for this enlightening presentation. Without much delay, I would like to now invite Dr. Gagan Saini, who is Director Radiation Oncology at Max Super Specialty Hospital, Delhi. Over to you, sir.
One second. Okay, I think now you'll be seeing my slides.
So they are visible, sir.
Thank you. Good evening, everyone. Thank you, organizers. So I'll be talking about the role of RT in malignant pleural mesothelioma. I must compliment the surgeon and the medical oncologist for setting a very nice stage for the talk. So radiotherapy is also a very loco-regional treatment, and my talk will also be a little bit, keeping that flavor in mind. So what's a mesothelioma? A mesothelioma is essentially a tumor of the pleura. So it's inside the pleura. And while a lot has been said, but I'll just at least add that one must always rule out a lung lesion and metastasis from other solid tumors using a PET CT scan to be very, very sure about the diagnosis. And stromal invasion helps establish the invasiveness where VATS surgery comes in, which is the reason why VATS assisted biopsy is more sensitive. And IHC, as was talked by Dr. Chopade, was always helps differentiate between the mesothelioma and atypical pleural proliferation. These are the diagnostic dilemmas which we should always traverse properly before we diagnose it as malignant pleural mesothelioma. Having diagnosed that, while the neoadjuvant treatments optimize the patient for surgery, and I'm talking about chemotherapy here, pemetrexed-based chemotherapy here, I would like to say that the role of surgery isn't unfortunately that well established. I totally agree that empirically we would all like the surgery to be taken place because we don't have a treatment better than that. But in all the studies, it has not been shown that how much benefit surgery really adds to the survival. So this is one original article which reported a retrospective analysis of about 1,300 odd patients, and addition of surgery did not really add much survival benefit. In fact, the same has been endorsed in the ERS ISTRO guidelines in the management of MPM. And I would like to also add that while it's not only the role of surgery which is questionable, even the role of RT is questionable. So setting that stage, I would like to go to the way we generally do things, which is the NCCN way. And indeed, surgery is quite very prominent here, with extrapleural pneumonectomy and pleurectomy or decortication being the two surgeries. And indeed, radiotherapy is also an inherent part of this treatment, which is called as the tri-modality treatment, starting with chemotherapy. So let's proceed with the role of RT. But we would need to understand the role of surgery first. So types of surgery, this is the EPP, the extrapleural pneumonectomy. I guess this cartoon should be able to explain it. So here is the mesothelioma, and it has been taken out en bloc with the lung and a margin of the pericardium and part of the diaphragm. And this is how the surgery has happened. This is a very toxic surgery. We're taking it's pneumonectomy also. And then the other one is pleurectomy with decortication, which is indeed a more safer surgery, where you basically take off the pleura. That's what you do. So, so what happens once the surgery is done and radiation happens? So this slide is just to give you a ballpark of how the patients behave at the end of the day. So this is how the graph will almost always look, no matter what you are doing, with a little bit here and a little bit there. That it's about 50% survival at 2 years, and stage 1s and 2s doing much better at 2 years at about 70%, and the stage 3s and 4s doing much worse at about 30%. So that is what you will get by doing all your treatments. And indeed, the same is endorsed by this table, which reports a multitude of studies where neoadjuvant chemotherapy followed by surgery has been done. And you can see these key results, which are about the same ballpark that I discussed. So as I said, the role of radiation therapy is questionable, primarily because we don't have enough data, primarily because it's a very rare disease. However, this is one randomized trial, SAKK17/04. This trial randomized these patients after neoadjuvant chemo and surgery. And the benefit of radiation was not really very prominently seen, with it being statistically insignificant. Nonetheless, as I said, that due to the lack of better options, we will always go in with the maximum locoregional treatment, just as we do with many other cancers in the body. And so what are the overall outcomes of adjuvant RT? When the intent of RT is local control and the target is pleura plus margin, and the dose is about 45 to 54 gray at 1.8 to 2 gray per fraction. This last thing of 25 and 5 I will talk about in a later slide. So this is how the results are. As I said, that you have your progression-free survival about 15 months, and your overall survival with intent to treat hovering between 15 to 20 months. That's how the patients ultimately behave. So there is a new a new kid in the block, so-called neoadjuvant RT, and what they are doing is they are trying to do the same RT in the same way as the Swedish trial for rectum did, CA rectum did. And this is accelerated hemithoracic RT followed by extrapleural pneumonectomy. So they give 25 grain 5 fraction to the entire hemithorax, and they take up the patient very quickly for surgery. So this paper reported that quite a significant number of people could complete their protocol, and the toxicity was there. These are the grade 5 toxicities, the deaths. I can see 2 deaths which are being caused. And this is my opinion that if you are going to use something like this, please make sure that the surgery is done as early as possible, because once symptomatic radiation-induced pneumonitis develops, surgery will be very difficult because of the symptoms. Nonetheless, this is the report with the median survival of 36 months. Looks slightly better, but it's maybe because the epithelial variants were more in this study. We can't be always very sure. So I guess with this, we understand where radiation stands. It's an empirical treatment to be given after surgery, and the idea is to create local control, which may translate into overall survival. So what is the target volume for malignant pleural mesothelioma? This is relevant for the radiation oncologists who might be listening. So it's interesting that there is no consensus guidelines for this. And most of the authors are using the RTOG consensus guideline for drawing of the pleura as an organ at risk, as a part of the OARs. So what you do is you basically draw the lung, and then you expand it 1 centimeter, you go 3 centimeters superior and inferior, and then you define the CTV inside the chest wall, and you exclude the intercostal muscles and nerves. You include, the intercostal muscle and nerves, and you exclude the vertebral bodies, sternum, skin, and other muscles. So something like this comes out. This is a web-found picture. So you take about 5 to 8 millimeters into the lung as well, and this is how the CTV should look like. You should be able to appreciate that the CTV is going all the way down here. This is the point of going 3 centimeters downwards, and this is how it is seen on the lung window. And in the PTV, so this is how we will get our isodose. So is there any role of including the site of drain or instrumentation in RT? Again, that's questionable, but this paper does tell us how we should be avoiding any geographic misses. So it's informing us that superior extent is at the border of upper border of T1. So this is how you don't miss out on the apex of the pleura, the thoracic inlet, and this is where instrumentation has taken place. This is how you must do it. Take all these muscles. Here you should be taking all these muscles. Here, this is how the instrumentation is being accounted for. You can see that this anterior edge is to be taken properly, so that because there's a lot of misses that are going to happen here, because it's difficult to manipulate the tumor close to the heart, and this is how you must draw it. This must be the at-risk volume, which must be defined by the surgeon. So this is how the radiation oncologist will be working. So which technology for radiotherapy? Now, in 2022, we all know that IMRT is the best, and we are way beyond IMRT also. But this paper is still quite relevant to be discussed, because they compared photon-electron versus 3D. And what is important is that when you're using a 3D or any technique which is inferior than IMRT, you are not able to cover these nooks and corners. This is one observation which I made long back when I switched over to IMRT, that these nooks and corners were so well covered by IMRT. Look, this is for 3D and this is for IMRT, and this is the graph. You can see that with IMRT the coverage is better. This, for the non-radiation oncologist, this hump which is up here shows that the coverage is much superior, and this is with the 3D. This is lame. This is a little lame. So there is a lot of area which is getting missed. So this area is getting missed here. Certainly, you should go in for IMRT. This one comparison from one of the papers I found was this. They used VMAT 3D. They compared VMAT 3D tomotherapy, proton therapy, and it's interesting that with tomotherapy, because it's basically an arc-based treatment, and even with those arcs, you are able to optimize for each slice separately. Maybe because of that, the coverage is, you're able to push in this high amount of dose of 56 gray. So this is my last slide. We should be using neoadjuvant chemotherapy, as has been very clearly elucidated before, and surgery must be optimized, DPP or poorectomy/decortication. And adjuvant RT should be done with IMRT so that each and every intended target is covered. So I guess I will stop here, and I thank you for your attention.
Thank you, sir, for this informative talk. Now we will move on to the most interesting session of the day, which is panel discussion. I will like to invite Dr. Ullas. He doesn't need any introduction, but I will just say he's Chief of Thoracic Medical Services and Senior Consultant Medical Oncologist at Rajiv Gandhi Cancer Institute, Delhi. And it is surely going to be a very interesting and informative panel. The panelists for today are Dr. Rakesh Kapoor. He is the professor and head of Department of Radiation Oncology at reputed PGIMS Chandigarh. Dr. Priya will not be joining in this place. Dr. Devyani has agreed to join. Other than that, we have Dr. Holly D'Souza, who is a medical oncologist practicing in Mumbai. Dr. Tanmay Mandal, who is a medical oncologist from Kolkata, and Dr. Abhinav Jabbar is a medical oncologist from Aurangabad. Over to you, sir, Dr. Ullas, please.
Thank you. Thank you for the kind words. And the success of the conference actually can be judged by Dr. Gagan Saini's, I just read a WhatsApp message by Dr. Gagan Saini. He has actually ditched a breast cancer conference for the lung cancer conference, and that too mesothelioma. So thank you, Dr. Gagan. Your comments on this?
Well, I had prepared harder for this, maybe.
Yes, that is what I was coming to, So Gagan like challenges. Gagan, if you can actually think about giving radiotherapy in a patient of mesothelioma, you can actually convince me to give radiation everywhere. So I would love to have you also as a part of the panel discussion, if you can stay. I'm sure Dr. Kapoor is always there to help the cause of radiation oncology. And Dr. Devyani, I must compliment you. I just joined in the last some time of your talk, and the talk was very nice. So congratulations, and looking forward to interacting with you.
Thank you. Thank you so much.
So panel discussion on mesothelioma. As every time, my first reactions when I first said yes, first of all, I should stop saying yes to everything which comes about from Ashay Karpai. He sent me a mail, I said yes. And then yesterday when I looked upon it, I said panel discussion on mesothelioma at 9 o'clock on a Saturday night. And ye kya ho raha hai? Where exactly are we going on to? What exactly is happening around? And I'm sure everybody would be yawning away to glory right now over there. I mean, at least if not everybody, I was yawning at the time at yesterday night when I was preparing for the talk. My subsequent reactions at that time basically was to try to keep everyone awake. I mean, whether it implies putting something over there or making some good learned discussion, I'm sure we'll have a good discussion is to do that. And I hope I'm able to, fulfill my obligation. So let's start with the case. This is a case scenario of 45-year-old male. This is a real case because I show you some, this is the patient which you treated. He basically comes with a history of cough with breathlessness. X-ray chest shows a right-sided massive pleural effusion. CT scan chest was done, which basically did a massive right-sided pleural effusion with underlying lung collapse. Pleural fluid cytology outside was suspicious for atypical cells, and ICD was inserted. Pleural biopsy was done, which said extensive necrosis with atypical cells. Now, this is exactly, this is my discharge summary. So I'm just showing you, this is not a something case which I'm cooking up. Everything same. CECD was done on 21st, X-ray chest, ultrasound abdomen, brush smeared nodular pleura, some atypical cells, pleural biopsy, atypical cells, cytology, atypical cells, IHC not done. And this is what the investigations basically are. So how commonly, I'll start with you, Dr. Devyani, have you seen this sort of a scenario, and what would your first reactions be?
Thanks. Yeah, I think the scenario is extremely common. And if we were to think of the most common etiology for a patient coming to a cancer hospital with this kind of presentation to the thoracic unit, you would think in terms of adenocarcinoma. But with this kind of a massive effusion, which with repeated cytologies coming back just atypical, but with no this thing, I would like to see the imaging to see if it fits into something else.
So imaging CT scan was done, which basically I'll show you I don't have the images, but I have the PET scan report actually, which again showed only some pleural thickening going on over there, and that's it, nothing else actually. So this guy is a non-smoker also. Can I go to my medical oncology friends, Dr. Abhinav and Dr. Tanmay? What is your, how would you approach this patient? And I'll tell you what I did in the end. Burnt my fingers and everything on that.
Thank you, sir. Sir, Abhinav here. Sir, yes, sir, I think IHC was not done. So maybe we should consider for like repeat biopsy and with IHC studies. That would be the...
This guy, Tanmay, has got a ICD. The lung has by and large expanded and there's very hardly fluid. How will you do? So ICD is already there. The fluid has been drained out. The lung has kind of expanded. There's nothing to go inside. So that is what exactly I would like to pick Dr. Devyani's brains. I'm sure the surgeons will get more this thing. I told my, we had a session on pleural effusion last month. And I very nicely said, my respiratory physician guy, let's do a thoracoscopy. And I called the patient from Dehradun. And he said, "Arey, jaun kahan se? Andar kuch hai hi nahi." So, in our institute, they also they create a hydropneumothorax. That is also, I asked them to do. They were not able to do that. So, Dr. Devyani, your thoughts on this?
So with this kind of a massive effusion, with the ADA being what it is and repeated cytologies coming as atypical cells, and you also mentioned that the CT thorax showed some amount of pleural thickening. I wouldn't say for a lack of anything else, I think a thoracoscopy would be the next step in this case, which would help us inspect the pleural cavity, look for any suspicious looking lesions, and hopefully get a more representative biopsy.
So, Dr. Devyani, the ICD was already in place. The lung had there was no fluid really inside over there. Can you still do a thoracoscopy? I mean, for medical oncologists, not so.
Yes, yes, you can. Yeah, it will be a procedure under general anesthesia. It won't be like a pleuroscopy, which could be done via an ICD. But
a surgical thoracoscopy.
A surgical thoracoscopy, like video-assisted, the VATS procedure, it can definitely be done.
Okay. Doctor, I think Abhinav has spoken or Tanmay has spoken? I didn't get.
Dr. Abhinav has spoken, sir.
Yeah. So, Dr. Tanmay?
Sir, I would also, if the biopsy, pleural biopsy, which is suggestive of suspicious of malignant cells are present, if we can try for an IST from that, I think it might be of some help, even if there are not too much amount of crush artifacts or whatever like that. That I think we can try. We can have a try for that.
Okay. So my concern and doubts, and we needed a lot of help actually. And you know what I did? So we are medical oncologists, we are lung cancer people. What I did was so mesothelioma never came into my, honestly, mesothelioma did not come into my mind at this particular time. I sent a liquid biopsy EGFR. I took out the fluid from there and I sent it for NGS also. So, I mean, a non-smoking guy, for me, the first differential actually was only towards lung cancer. And this is a real case. So I'm, the next down the line, we had a liquid biopsy EGFR because I thought this will come positive and then maybe we can give the guy something over there, but nothing. So my doubts and concerns or my learnings that I want from the radiologist or the surgeon is, are there any radiological features to differentiate or point towards mesothelioma? Because I can show you a typical case like this, which presented as adenocarcinoma, which I showed in the last panel that I did actually.
So you're right, Dr. Ulhas, it's very, very difficult to, very conclusively differentiate between an adenocarcinoma with pleural deposits as against a mesothelioma. But like Parang had said in this talk, really elucidated very elegantly actually that if there are nodular deposits and a very well-defined thickening of the pleura, which is going on the mediastinal pleura and the parietal pleura, and especially unilateral disease, no other lesions seen in the lung, then maybe you need to start thinking of mesothelioma. And having said that, even a history about the patient's workplace, any history of asbestos.
I will come to that, Dr. Devyani. Yeah. The workplace, I will come to that. Dr. Rakesh Kapoor, sir, does your radiologist actually report like this? It's very easy to say, nodular thickening and all. I mean, all that they write is some amount of pleural thickening is seen. I actually checked the last 15 radiological reports, and I hope none from my institute is listening to me. Nobody comments. I mean, that's my one. I mean, I'll ask Devyani and Dr. Rakesh Kapoor. Dr. Rakesh, sir.
Dr. Ulas, I think what Dr. Devyani has said, it is a difficult thing to comment. You have nodular deposits, but you can't immediately say whether it is a mesothelioma or not. You can't pinpoint it. It is difficult. But one thing is definitely there, our radiologists, they definitely try to correlate the history, because, you know, in mesothelioma, most of the farmers, those who are working in the chemical factories, if you have that history, then they definitely pinpoint at the end and they write something like that, so that the suspicion grows more to us, because in this region somewhere the asbestos exposure is there in the pesticides. It was there earlier. We did a study, I think Alok is here. 5 to 10 years back, we were a team from PGI. We all were together and we studied that in the water table of this area, because of the free fall use of the pesticides through the helicopters in that area for the BT cotton. So we found that some of the patients, they came and we had a suspicion in PGI. But still it is very difficult. It is difficult because the presentation can definitely go with metastatic deposits as pinpointed. So you have to be very cautious. And the exposure time is also very long. It can vary from 20 years to 40 years. So it is not easy to comment.
True that, sir. So Dr. Devyani, any specific radiological modality or a CT or a PET, MR, something else, or a diagnostic contrast and CT scan is good enough? And a PET scan, as Gagan said.
Yes, so CT thorax and a PET if diagnosis, nothing else over and above, nothing else.
Okay. Fantastic. So my concerns, I think Tripti is there, who is writing some good points over there. Dr. Tripti, please come. And then my medical oncology friends over there. And is cell block good enough, Dr. Tripti? A lot of time, you know, we have done a lot of studies in which the pleural fluid, if we make a cytology block and everything. So is cell block, and you know, I'm being very honest, I'm here to clear off my doubts actually, rather than to conduct a panel discussion. So is cell block good enough?
So cell block is good enough. The only thing with cytology is that whenever there is sarcomatoid morphology, it is not easily shed off in the pleural fluid. So that is why we tend to miss. And usually in this scenario, like lot of reactive mesothelial cells, and you cannot histologically distinguish. So sometimes P53 and desmin, there are some markers, which and TTF1 obviously. So in this scenario, even if very scanty atypical, but if it is highlighted by TTF1, you can clearly rule out mesothelioma. So So even if scanty cells, and with this kind of clinical scenario, markers like D240, TTF1 and CK7 would be helpful.
Okay. So again, Dr. Devyani, on this biopsy thing, you know, so what happens is we do a lot of medical thoracoscopies and we do a lot of cryobiology, our respiratory people do. And they do a lot of, whenever you do a pleural biopsy, you know, every time I do that, my pathologist will ask me, ring me up and say, "Isme mesothelioma to nahi lag raha," because we are seeing some spindle cells. Because whenever you take a biopsy or chunk from the pleura, you will obviously see some spindle cells. So what is your experience on that?
So thankfully, we are blessed with extremely good pathologists and radiologists both.
And so are we.
Like Trupti said, a lot of times on the cell block itself, they give us the report of a mesothelioma. And if not, more often than not, even a CT-guided biopsy from the thickened pleura yields a diagnosis. And a number of times we've actually had to do a thoracoscopy to go in, visualize and get a biopsy has been quite rare. Okay. But in the parts that we have had to do that, we've been able to actually pinpoint the more pathological looking pleura and the deposits there and get enough tissue for our pathologist to make a comment.
So Dr. Tripti, any pointers on the histopathology? Like I said, the spindle cells or something, I mean, you know, which will, you know, tissue is always the issue. If you want to save time and do this, or you have to do TTF1 and CALD and everything.
Yes, we have to do. So initially high index of suspicion, imaging wise only pleural, no lung mass, because mesothelioma can look like anything under the sun. Any metastatic adenocarcinoma, metastatic carcinoma can look like it. So always we put like 2 mesothelial markers, and TTF1 is always there in the panel with this kind of scenario. And sometimes even sarcomatoid carcinoma, they are very low sensitivity. So that time only just some cytokeratin and D240 will help. Otherwise, it is very difficult for pathologists also.
Now, Dr. Tripti, a very relevant question. I'll ask my medical oncology people first, and then I'll take your comments on this. So the initial report, Dr. Mandal, comes as a poorly differentiated carcinoma, TTF negative, P40 negative. Why is this not NSCLC, NOS, and let's conserve the tissue, send it for NGS, Just forget this is a rare tumor panel discussion. If this was a normal lung cancer panel discussion in which me and Kumar were discussing, why is this not a NSCLC, NOS? So first of all, no, Dr. Tripti, you're the pathologist, you will have the last word. Fine, let me put my doubts first. So Dr. Mandal or Dr. Abhinav, anyone? Okay, the medical oncologist seems to have Abhinav.
TTF1 is negative, so it could be definitely NSCLC. Maybe we need to put furthermore markers for mesothelioma.
So, Dr. Abhinav, what I want to ask you is that in all the cases where TDF and P40 is negative, does your pathologist or you ask your pathologist to put a WT1 and calcitonin?
No, sir. Morphologically also it will help, sir. Morphologically, if we look, if it is more of like mesothelioma, like, then we might consider adding that.
Tripti only said that it can look like anything.
Sir, but if it's P40 is negative, then definitely I would ask. The TTF1 is negative.
So my only reactions on this is, if I knew I was to become an oncologist, I would have taken my Father Robbins and my that Katzin book more seriously in my second MBBS. These are the only two books I didn't read seriously, and look what I have become. So Dr. Tripti, tell me, why is this not an NSCLC, NOS?
Okay, fine. So whenever we do TTF1, P40 and decide our diagnosis, the first thing is that imaging wise, there should be a lung mass.
Okay.
Just a second. Yeah. So there should be imaging wise, there is lung mass. Now in this scenario, and before calling any tumor as NSCLC, NOS, you should rule out. You should rule out any other sarcomas. You should rule out sarcomatoid mesotheliomas, hemangioendotheliomas, and only when you are sure it is some kind of carcinoma, that time give it as NSCLC, NOS. So by default,
the CK would be what in mesothelioma?
So cytokeratin 7 is strong and diffuse in both mesotheliomas as well as in adenocarcinoma. So that is why it's a very high index of suspicion, and then you always put WT1 calretinin.
So exactly right, Dr. Tripti, and that is why we are also blessed, Dr. Devyani, to have great pathologists with us. So every time we have a diagnosis where P40 and TTF1 is negative, a call will come, boss, lung mass hai ki nahi hai, patient ki history kya hai, asbestos hai ki nahi hai, and that is how they actually go and sign off the report. Again, hats off to the pathologist. I mean, the only thing that I could see in the pathology was a number which was written on the slides. Agar 36 hai to mesothelioma hai, 63 hai to adenocarcinoma hai. That's the only thing I remember from my second year MBBS actually. Okay, Dr. Mandal. Does your pathologist mention epithelioid versus non-epithelioid, and Dr. Kapoor or Dr. Devyani can also come in? Do they mention regularly in their reports about epithelioid versus non-epithelioid mesothelioma?
Yeah, Dr. Ullas, they mention. They mention it is not difficult.
Fantastic. So Dr. Devyani?
Yes, absolutely. They do mention it.
Dr. Abhinav?
Yes, sir. They mention.
Okay. Dr. Gagan? Somewhere in Max? Or you don't look, you have to give radiation?
This is not a very common scenario, but yes, once it's done, all the things are thoroughly mentioned.
Fantastic. So we need
to last. Can I intervene for a minute?
आप आदेश करें, sir.
I'm very sorry. Gagan is already here. I just got a call from the medical superintendent PGA. There is some administrative urgency. So I'll have to take that. I think Gagan has already dealt with all the nitty-gritties related to radiation. So
the loss is only about, sir, but you please take care of your work. Thank you, sir.
I'll just, I have responded back on the phone call. I said I'll reach in 15 minutes to the hospital.
Not an issue, sir. I'm so grateful
give
that
me that liberty. You know, it is a hard time in Punjab right now. The government shifting is going on.
Sir, all the best for that, sir. हम लोग भुगत भोगी हैं, दिल्ली वाले.
I'll take leave from all of you. Thank you so much. But I think Gagan has covered most of the things. He has given all the nitty-gritties on that.
No issues, sir. Thank you.
Thank you so
So
much.
moving forward, my doubts and concerns for the medical oncology people. And Dr. Abhinav and Dr. Tanmay, I would want some honest conversations. Saturday night, 21:00 hours, even without a small patiala, let's have some honest conversations. Okay. How commonly do you see mesothelioma in your practice? Everyone, Dr. Abhinav and Dr. Devyani and Dr. Gagan.
Sir, Dr. Tanmay here. It's not very common to see a mesothelioma. In TMH, still we used to see some, but in Kolkata, what I have seen in the last 1 to 1.5 years is, I think, some 2 or 3 patients maximum. Otherwise, I have not seen mesothelioma. And history of asbestos exposure, actually, I don't even ask for that much. It's an indirect way of asking. Means when the diagnosis of a mesothelioma comes, then only we go for asking.
No, but how many people, Dr. Mandal, do not have the asbestos exposure? I mean, I'll put my hand up and say, not many people at least in my setup, will give a history of asbestos or cement exposure. We don't get that actually. So that's my.
So we also don't have that much. No one gives a history of asbestos exposure in whatever 2 or 3 patients which have. No one had given a history of asbestos exposure.
Let me talk to Dr. Abhinav. Abhinav.
So yes, sir, as Tanmay sir said, we don't see. I've rarely seen. After coming out from TMH, I've never seen, still now, I've never seen single case. Although recently I saw one case of peritoneal mesothelioma. That was also like, it was query. So,
okay.
It's very rare.
Dr. Devyani?
So being in tertiary referral center, we do end up seeing a couple of more mesotheliomas than we would otherwise, but very uncommon. So I would say for every probably 100 patients of non-small cell lung cancer, you'd see probably 1 potential mesothelioma. Yeah. And asbestos exposure, very uncommon. I mean, it's very difficult to pinpoint.
Okay, I think for the surgical oncologist, I will ask this very important question to Dr. Devyani first. The second one, how do you assess operability? You have said, but just for a nutshell, if you can tell. I struggled with the second question. Initially, I put, is it ever operable? Then I thought, is it ever inoperable? A surgeon, when a surgeon said it's never inoperable. So only if it's post-mortem or you can see the table from it's inoperable. So is it ever operable, inoperable, any point in doing an R1 resection?
Right. So operability, an operable mesothelioma, like this thing is more often than not a fit patient. So if the patient is not fit, all this discussion is moot.
Fair
and secondly, it has to be something usually limited to the hemithorax. So anything which is going like beyond the diaphragm, looking like there are deposits on the abdominal side of the diaphragm. Sometimes we've seen liver being infiltrated or creeping across to the contralateral side, or heavy nodal burden. All these are no-nos as far as operability is concerned.
Pericardial involvement?
Is all right, because pericardial excision is actually a part of either of the 2 surgeries. So pericardial.
So what all do you take out? And my always concern is, I mean, what do you leave here? I mean, what happens after that? I mean, tell me about that procedure. This is what I ask Dr. Darlong all the time, chhod ke aaye ho, wahan hawa hai kya, wahan sab kuch? Then walk me through it.
So if it's an extrapleural pneumonectomy, then like you said, hawa hi hai andar, because you end up removing the parietal and the visceral pleura. The lung is gone, the pericardium is gone, and in most cases, the diaphragm is gone as well. But if it's an extended pleurectomy decortication, which we are doing more and more and trying to do more and more, in that case, the lung is left behind. So everything else but the lung. Yes, in an EPD. Yes.
Okay. Gagan, how comfortable are you in giving radiation after that? Yeah, and where do you give radiation to? I mean, I saw you struggling actually on that. That was not the usual Gagan Saini, which we normally know. You were thinking, kahin wo Saturday night ka sach wala baat aa raha tha na ki chhod dete hain.
So seriously, I mean, the dose that is required is more than 50 gray for any sort of control, and that too required to the entire pleura. And then with that lung in place after their decortication, I mean, the chance of pneumonitis is almost Devyani has done a decortication. then perhaps on the tumor board, I will ask them, that what is the area you are worried about? Where are you really worried about? So maybe that can be one approach.
No, but there is no point in giving one targeted radiotherapy to the one particular, no place. I mean, Gagan, that's what, I mean, in our tumor board also they say, it's a pleura. So you need to give it to the entire hemithorax, right? I mean, there's no point in giving it to one particular point.
I agree with you. I agree with you. It will be done on case-to-case basis. Suppose it's an extensive pleural disease with, which is stuck everywhere. And, they could not do an EPE because EPE is toxic and they have done decortication. Then there's no point in giving radiation there because the kind of pneumonitis that you will end up dealing with is going to be very high.
No.
Can I actually ask you a question?
Can I just make a comment and then it's not the surgeon or the radiation oncologist, the medical oncologist who will have to bear the pneumonitis.
That's why I said you will be dealing because later on you will be giving Nivo and Ipi also. So the kind of mess that gets created. So that is not the kind of case I would like to give radiation.
Dr. Devyani,
unless in the tumor board I find that. Unless in the tumor board, I find that, say Dr. Devyani is informing that, okay, fine, this anterior part was stuck, rest we have been able to do. So maybe there is no harm in giving, since you have already completed your chemotherapy, Dr. Ullas, and you are just waiting for recurrence to start your immunotherapy, no harm in giving some radiation if pneumonitis can be avoided with radiation. So that is the limited space. But yes, after EPE, where there is no lung and the chance of pneumonitis is less and the patient has recovered, I think we should go in for hemithoracic RT done in a proper way.
So, Dr. Devyani, your comments.
My question to you here, Dr. Gagan, is the world is moving away from a pleural pneumonectomy to saving the lung as far as possible. And even the MARS-2 trial, if we see the protocol, the radiation part of it has been done away with completely. So if you have a disease where you have been able to achieve a maximal safe resection, so to say, with a pleurectomy decortication, do you still think of hemithoracic RT in such cases, or is that out of the picture completely?
As I just said that, it will be, if you're doing a pleurectomy decortication, I'm not keen at all to give radiation unless we are able to, fine tune our radiation to some particular point or the other.
Absolutely.
Okay. So that is nice. Please, if everybody 64 delegates were listening to us, read in between lines about what Dr. Gagan has said. Rest, I will leave it to your imagination. Dr. Devyani, it's okay, Gagan. I need to have 1 point above at you once in my lifetime. No, yaar. Okay.
You always have it. You always have it.
Devyani, after ICD, let's say you're going to go for neoadjuvant chemotherapy. Can I do my pleurodesis, or what about the
rather avoid it actually, because a pleurodesis incites an extremely fibrotic reaction which makes any future surgery fraught with challenges.
So let us say that, Dr. Devyani, because time is limited, sorry, I'm learning from you. So let's say we have done a ICD, the biopsy report comes as mesothelioma. You ask us to give neoadjuvant chemotherapy. Then will the tube stay inside for 3 months?
No, it won't. Please remove the tube as soon as the patient's symptoms
so
are
that is the point which I wanted to bring out actually. That's what we do. We do take out the tube. So this is our tumor board, and this is during the tumor board, the COVID tumor board that we had. Surgery upfront, NSCT, I think we have discussed. I'll only answer this question. How many cycles, Dr. Abhinav? How many cycles of NSCT adjuvant?
So 3 cycles, 3 to 4 cycles.
3 to 4, I think. And we are also learning, moving towards finish all your chemotherapy prior. Don't wait for the surgeons and then give 1 cycle. The 4th cycle chemo never gets given. That's what the point is. You know what? Kabhi theek hi nahi hota to mushkil ho jati hai. It's better to give away all the 4 cycles. So this is a histopath report. Tripti, if she is there, this was the patient. Atypical cells were positive for CK56, WT1, calretinin, negative for all these markers actually over there. 3 cycles of pemetrexed. This was the PET scan report. This patient underwent surgery. Whatever. Dr. Devyani, and Gagan, just read this report properly. And this is the histopathology report. Important thing is, the pericardial cut margin is 1 millimeter away. It's an epithelioid mesothelioma, less than 50% of residual tumor. And the moment of truth basically comes with the parietal pleura is involved, lower lateral chest wall and the nodule on the pericardium is involved. With this report, Dr. Gagan and Dr. Devyani, RT yes, RT no.
So I'd like to ask, I'd like to go back to the baseline imaging and ask that, this nodule on the pericardium, how...
No, we were not able to see. Not much.
So Dr. Devyani, what I will ask, of course, she was of course not involved in this, but I'll ask the surgeon that, what is the location of this nodule? I mean, what is the actual ramification of this presence of this nodule? Is it a part of the same
specimen? When you do the surgery, Dr. Devyani, do you think you shave off? I mean, that's the word sometimes what do you do?
So in this case, your surgeon has done a fantastic job and has taken the pericardium oblong with the specimen. So I wouldn't really be very concerned. And as we say, we aim for a maximal cytoreduction in mesothelioma, which is more than achieved. So I would be comfortable not radiating this patient as well.
So, I mean, again, Dr. Devyani, asking you a very point blank question. Happy with an R1 resection?
Yes.
In this case?
Yes.
No heartbreaks?
No heartbreaks.
Okay, Gagan, RT yes, RT no. No heartbreaks.
Wish we could give safe RT in a scenario like this, but since we can't, we shouldn't be doing it.
We also did not give. In fact, this patient is absolutely, I mean, so this is the story continues. We just finished with chemotherapy and gave. I have just for the purposes of this, I think I have told that the patient has got recurrence. The patient does not have a recurrence till now. It's been almost 2 years. I wanted to ask my medical oncology friends, immunotherapy in mesothelioma, yes, no? Abhinav?
Yes, sir.
Have you given? I haven't.
Yes,
okay, and that's a good one. Dr. Mandal?
But the data shows, sir.
That data
because anyways, chemo doesn't have, like, it doesn't give so much benefit.
Okay. Dr. Mandal, immunotherapy, yes, no? Dr. Mandal has gone to give immunotherapy, I guess, already. Any biomarkers? Dr. Tripti is here?
Hi, yes, I'm there.
Yes.
But sorry, I missed your question.
You're walking somewhere. Wow, good. That's the fun of virtual meetings, no? I love virtual meetings.
Yeah. Sorry, I missed your question. I got disconnected.
Any biomarkers for mesothelioma, immunotherapy, any prognostic markers?
You mean like PD-L1 and
something of that sort, yeah. For immunotherapy. The long and short answer is there none.
Yeah.
There's no biomarker, there is no role of PD-L1. The only thing is epithelioid and non-epithelioid. People with non-epithelioid did much better. But I think the important thing which I wanted to bring about is Nivo-EP had the same 18.6. In the epithelioid one, the chemotherapy did work better than the other one. So that is why the graphs are actually above. Otherwise, if you see 18.6 and 18.7 everywhere. So that is the thing. So my conclusion on mesothelioma basically are, first of all, thank you. Thank you actually the surgeons and the radiation oncologists actually and pathologists for helping us learn. I mean, honestly. And I hope I am able to keep the people awake at that particular time. So thank you. I had a fantastic time. Looking forward to meeting everybody in person. Thank you.
Thank you.
Thank you. Thank you so much.
Thank you so much.
Thanks a lot, Dr. Ullas. It's always nice to have you at a panel. It's always very interesting panel and nobody dodges off during a panel.
No wonder you give me a 9 o'clock in the evening.
Yeah, therefore we choose you. Thanks a lot, sir. Thank you. So over to Dr. Nandini for closing remarks.
Thank you. Thank you, sir. We really enjoyed that panel. And audible?
Yes, you are audible. Yeah.
So we really enjoyed the panel. Thank you, sir. Thank you to all the panelists for being here till the end. And now we come to the end of the day 2 of our virtual education program. And at the outset, I would like to thank all our faculty and panelists for participating and being present throughout. And a special thank you to everybody who agreed at the last minute and were present. And also, I would like to thank our sponsors, AstraZeneca and Pfizer, and to thank the Cancer Research and Statistics Foundation and our organizing committee chairperson, Dr. Kumar Prabhash, Dr. Ashay Karpe, and Dr. Vijay Patil, and my colleagues, Dr. Amit Agarwal, Dr. Ajay, Dr. Gurvinder, Dr. Alok, Dr. Rishabh, and Dr. Kushor, without whom we would not have managed to pull this meeting off. And last and not the least, to thank the Horizon team who helped us organize this meeting and helped us with every little detail along the way. So thank you so much. And a big thank you to our audience for being with us through this meeting. Thank you, sir, and thank you, everyone. Good night.
I must compliment you guys for having a fantastic session. It was nice.
Thank you, sir.
Thank you.
Thank you, sir. Thank you so much.